Vanjana. Should I begin?
Yes, ma'am.
Good evening, everyone. Welcome to the second day of the ICOG certificate course on Urogynaecology and pelvic floor repair. I am Dr. Suman Sinha, Chairperson, Vaginal Surgery Committee, FOXY, and convener for today's course, with Dr. Sandeep Nikhade, a very brilliant young gynec from Nagpur, as coordinator. We had a very successful day one session where galaxy of star speakers expressed their views on relevant topics, which was very impactful and of clinical importance. We had a full house attendance. The registration has crossed 550. For second day, also, we have created a very tailored program, carefully selected to ensure accessibility in guiding the views to understand the fundamental knowledge with evidence-based guidelines. At the very outset, I take the delightful opportunity to welcome all the dignitaries, our esteemed speakers, chairpersons, conveners, Dr. J.V. Sarma sir, Dr. Kavita Varnawal, coordinators Dr. Meena Mahalingam, Dr. Sandeep Nikhade, Dr. Mukta Agarwal for shouldering each other responsibility. I welcome our respected ICOG chairperson, a very good friend of mine, a hardcore worker, and he makes each and everyone to work also, Dr. Parag Viniwale, to our this platform. I welcome our respected participants for logging in today, and a very heartfelt welcome to my dear overseas speaker from Texas University, Professor Dr. Apurva B. Pancholi. He is professor in urogynecology in Texas University. Next, I am fortunate to welcome our Honorable Chairperson-elect ICOG, who is an epitome of hard work, persistence, and perseveration, Dr. Sheila Mane. She is popularly known as PPH Lady. She will be joining in between the session as he is busy somewhere. And next, I'm grateful and happy to introduce and welcome a very friendly, dedicated, and empathetic creative leader, Chairperson-elect ICOG, Dr. Sadhna Gupta. So can I have Dr. Sadhna Gupta CV? We all know she has recently been elected as Chairperson ICOG, and she's very active. And I think every month he is giving us a theme to learn. Every time this is very, very, I mean, academically sound, and blogs he is writing and on very, very important topics. These days I'm reading her blog on endometriosis, which is very helpful. So welcome, Sadhna madam. If you are there, we would like to hear your pearls of wisdom.
Dr. Parag will be addressing personally. Parag.
Madam, your
No, Sadhna, you have to start. It is your turn today.
So, good evening, everyone. A warm welcome to another certified course of ICOG, which is actually USP, which is identified with the Indian College of Obs and Gynecology. And the Dr. Parag Viniwale, who is very, very like a dedicated person since a long time. And now ICOG is fortunate to have him as a ICOG chair. And under his leadership, ICOG is going far ahead and with a great direction. My regards to Dr. Sheila Mane, who will be chair-elect and who will be chairing ICOG next year, and Dr. Ashok and Dr. Sarita Balinam, Secretary ICOG. So congratulations, Dr. Kavita, Dr. Suman, and Dr. J.V. Sharma. So it is a hierarchy, and we see people who have done immense work in field of urogynecology, and we have esteemed faculty and a very, very well-crafted sessions, which is taking actually the old thing, the always constant thing like recurrent UTI, and the emerging thing, the cosmetic gynecology. So it is the thing, India is always a country where we have all old issue, we have all challenging issue, and we have all the issues which is, we can say it is related to a very high socio-economic class. So we have Dr. Aparna Hegre, Monica Gupta, Dr. J.B. Sharma, Dr. Meera, Dr. Ragini, Dr. Purva, Dr. Lakshmi, Kavita Vandwal, Amit Tandon and Amita Jain. So it is a galaxy of faculty who have done immense work in this field. And we truly hope and believe that all people who have registered for this certified course will have a deep insight and will have a deep understanding of the subject, which sometimes poses us complex challenges, and what to decide, like a new thing, energies and the laparoscopic approach of bulk suspension against vis-a-vis the conventional thing. So a warm welcome to everyone, and we wish you happy and the enjoyable learning and the understanding. Thank you very much.
Thank you, madam. Suman, madam, you are muted. Thank you so much,
Okay.
madam. Yeah.
Dr. Parag, we would like to hear from you. One word of blessings.
All right. So since Dr. Sheila Mane is not joined, I'll just quickly
Yes.
take a minute to appreciate tremendous effort put in by three of my conveners, Kavita, Suman, and of course JB Sharma. And Sandeep, welcome to the ICOG platform for the first time as the coordinator, along with Mukta and Meena. I'm sure it's going to be a great learning experience for all of us for the next 2 days. Yesterday, we had some wonderful lectures, and I'm sure today and tomorrow, all the delegates will go back with some great insight into the subject of urogynecology. My best wishes for the program. Happy learning, and don't forget to attempt the post-test, because if you secure more than 50% marks on each day, then you are eligible to receive certificate from ICOG. Thank you very much.
Thank you, Dr. Parag, for your very lucid words. And now I'm supposed to let you know the overview of day 2 topics. There will be 3 sessions. In the first session, we have Dr. Aparna Hegre, Dr. Monica Gupta, Dr. J.B. Sharma as the speaker. And to chair the session, we have Dr. Hafizur Rahman, Dr. Meena Samant, and Dr. Ranjana Khanna, madam. All are ICOG GC members. And in the second session, we have Dr. Meera Raghavan, Dr. Ragini Agarwal, Dr. Apurva B. Panchole, and Dr. Lakshmi Sikhande, madam, as the speaker. For chairing the session, we have Dr. Bharti Maheswari, Dr. Benita Singh, and Dr. Bidya Thobi. And in the last session, we have Dr. Kavita Barnwal, Dr. Amit Tandon, and Dr. Amita Jain as the speakers. And to chair the session, we have Dr. J.B. Sharma, Dr. Charmila Ayabu, and Dr. Kavita Singh. After all the sessions are complete, there will be a post-test, as Dr. Parag has already said, and to achieve the ICOG certificate on urogynecology and pelvic floor repair, it is mandatory to achieve 50% marks on each day. So all the participants are requested to listen to the speakers carefully. And now I'd like to have the CB of our coordinator of today's, Dr. Sandeep Nikhade. So here on the screen, we can see his CV. He's director of Life Spring Hospital and Parvati IVF. He's also director Milestone Hospital, Nagpur, India. And he's consultant laparoscopic as well as a pelvic surgeon. So welcome, Dr. Sandeep. And I hand over the podium to you for the further proceedings. So can you, you have to introduce all the chairpersons. Maybe Dr. Hafizur will join late, but we can start 1-2 lines only. Yes.
Sir, you have to unmute.
Yeah.
You are muted.
Yeah. So on behalf of Foxy and ICOG, it is my absolute pleasure to extend a very warm welcome to each and every one of you joining us for this incredibly important webinar, Foxy ICOG certification course on urogynecology and pelvic floor surgery. You all are aware that pelvic floor disorders are far more common than many people and realizing affecting millions of individuals of all ages and genders. Yet, despite their prevalence, they often remain silent. So let's open up this issue and gain some knowledge from this webinar, wonderfully crafted webinar. So for this first, I would like to invite our first chairperson, Dr. Ranjana Singh, madam.
Khanna madam.
Rajana Khanna, madam.
Can I have CV चाहिए?
Yeah.
Yes.
Yes. She is the National Vice President of FOXI 2017 and is the RCOG Governing Council member 2021-25. So I invite Ranjana Khanna, madam, to introduce the first speaker, Dr. Aparna Hegde. But then she is yet to join.
Introduce Dr. Meena Samant also.
Yeah, yeah. Another chairperson is Dr. Meena Samant. She is senior consultant and HOD at Patna, Holy Family Hospital, Patna. Governing Council member of the ICOG in 23-25, and she is the president of Patna Obstetric Society in 23-24.
Thank you, doctor. Thank you.
She was a vice president of ISOPAR. And the next chairperson is Dr. Hafizur Rahman, is the professor of obstetrics and gynecology at Sikkim Manipal Institute at Gangtok, India, and is a member of ICOG Governing Council in 21-23 and 24-25. He had many awards like Foxy Future Award in 27, then IEC Sun International Traveling Fellowship in 2017, and won several awards for paper presentations also. So I invite all the chairpersons for this webinar. The first speaker is Dr. Aparna Hegde. Madam is there?
Dr. Aparna has come?
Not joined yet, ma'am.
Not yet joined.
Then second speaker.
So second speaker then?
I talked with Dr. Monica Gupta. She is yet to join. She will take another 5 minutes.
And Dr. JB Sharma has joined?
He is not responding to call.
The phone also. So we can start with the second session. You ask Dr. Lakshmi Sukhande madam is here.
Ma'am, she's not. She's busy somewhere right now.
Actually,
Sandeep.
Dr. Suman,
Lakshmi ma'am is there.
Sandeep.
Yes, madam.
Hello.
Lakshmi ma'am is there.
Sandeep,
Yeah, yes, madam.
can you hear me? Yeah,
Yes,
I am
yes,
ready
madam.
now.
Okay,
If you
madam.
want, I can start. Yeah.
Yes, madam. Please, madam.
so I'll introduce
Yeah.
Lakshmi.
Yeah.
Just a minute. Let me
Hello,
open my
Nilima?
PPT. Huh.
Please share the CV of Lakshmi, madam. Lakshmi, madam, don't
Talk
need
हो
any
जाने दे, 15
introduction.
मिनट रुको.
आपका तो CV पढ़ रहे हैं हम लोग.
Lakshmi, madam.
5:30 से 6 के बीच में आ जा बोलो. लेट मत कर.
Yeah. So should I start with the CV by introducing Dr. Lakshmi?
Yes.
Yes, madam.
Yeah, then can I have the CV back? It's Aparna's CV now again.
Let me share. I will share my PPT. The first slide is CV slide. Yeah.
Okay, do that.
Yeah. I will make your life easy. Yes.
A very good evening to everyone. And today I have the distinct pleasure to introduce Dr. Lakshmi Srikhande, who has been the past chairperson of ICOG and National Corresponding Editor, Journal of OBGYN of India, Jogi, since the last 8 years, National Corresponding Secretary, Association of Medical Women of India. She's very dynamic and member SAFOG Education Committee, Vice President-elect ISOPAP 2016-17. And
yes,
she's
madam.
basically the medical
Lakshmi,
director
madam,
and
पहला talk ले रहे हैं अभी. तो madam.
Hello, Ranjana.
Ranjana ma'am, you're muted.
oh my God,
I am mute.
you all didn't hear anything what I said.
Half of
Okay.
it only, half.
Okay. So, Dr. Lakshmi Srikhande, Medical Director and Senior Consultant, Srikhande Hospital and Research Center Private Limited, Nagpur, Maharashtra. She's been the chairperson of ICOG 2022-2023, National Corresponding Editor, Journal of OBGYN of India, Jogi, since the last 8 years, National Corresponding Secretary, Association of Medical Women India, member SAFOG Education Committee. She's very dynamic and she is also the president of Association of Medical Women Nagpur 2021 to 24, President Menopause Society Nagpur, and she's delivered 32 orations, 550 guest lectures, lots of publications, and does a lot of work. So welcome Dr. Lakshmi to deliver your talk.
Thank you. Thank you, Ranjana. Just a minute. It's lost. Thank you, Ranjana, for that kind introduction. Friends, topic for my deliberation is recurrent UTI. Recurrent UTIs are not an uncommon issue, affecting around 30% of all women who have had a UTI. By definition, recurrent UTI is defined as 2 or more UTIs within 6 months or 3 or more within a year. These infections can be a significant health concern, often requiring ongoing management and potentially leading to kidney damage if left untreated. Differentiating between reinfection and relapse is crucial for management. A recurrence is termed as reinfection if the interval between the two episodes is longer than 2 weeks, if a different uropathogenic strain is documented, or if a sterile culture when the patient is off the antibiotics and you are documenting a sterile culture between the two UTI episodes, then this is termed as reinfection. Whereas if the interval between the two episodes is less than 2 weeks, this is considered a relapse. Relapsing infections often require additional evaluation with urological imaging, which is rarely indicated in recurrent infections. So these are various risk factors for recurrent UTI. I have highlighted few very important risk factors in females, that is inadequate or incomplete treatment of the initial acute cystitis, increasing bacterial resistance to antibiotics because now everyone is using antibiotics left and right, faulty wipe direction, females who are using vaginal douche, and then there are many other risk factors. So what are the symptoms? Recurrent UTI symptoms are same as that of any typical urinary tract infection. The common symptoms include dysuria, suprapubic pain, cloudy urine, frequent urination, urinary leak, urge incontinence, or hematuria. So how to diagnose? Diagnosis requires a comprehensive evaluation to determine the underlying causes and contributing factors. And it starts with the medical history, where you have to take the detailed history of the patient's record. This includes asking her about the episodes of UTIs, any underlying medical condition she is suffering from, any recent urinary symptoms. Thorough physical examination may be performed to detect signs of infection or underlying conditions that could contribute to recurrent UTI. Investigation starts with plain, simple urine analysis because this is the key diagnostic test in UTI. It is done to document the presence of white blood cells, red blood cells, bacteria, and other abnormalities. Elevated levels of white blood cells and the presence of bacteria in the urine indicate infection. A crucial step involves conducting a urine culture to pinpoint the specific type of bacteria which is causing this particular infection. And this will help us in choosing the best antibiotic for that particular episode. Urine cultures are also necessary to differentiate recurrent infections from relapsing infections. Diagnosis of recurrent UTI relies on clinical symptoms and urine cultures, with imaging reserved only for complex cases. So the indications for imaging include if there is persistent hematuria, if she is giving you a history of kidney stone, if repeatedly you are finding proteus in her culture, and if it's a relapsing infection. Imaging studies are done when you also want to assess the structure and function of the urinary tract. Common imaging methods include ultrasound, CT scans, or IVP. Performing a cystoscopy to diagnose recurrent UTI is rarely indicated, as this might only induce an ascending lower urinary tract infection, and it rarely provides any useful clinical information. When to refer them for specialist? Specialist referral is indicated if this is a complicated UTI, if you need surgical correction to treat UTI, or when the diagnosis of recurrent uncomplicated UTI is uncertain at your level. How to treat? They are commonly treated with antibiotics as the primary course of action. The choice of antibiotic and the duration of treatment depend on various factors, including the patient's health condition and the specific type of bacteria identified in the urine culture. Treatment of recurrent UTI always starts with the behavior therapy. That is, you have to maximize the personal hygiene factors, avoid spermicides, tell them to correctly wipe direction, maintain hydration, and using vaginal estrogens wherever it is appropriate. How to use antibiotic prophylaxis in the management of recurrent UTI? This antibiotic prophylaxis successfully controls recurrent UTI, but alternative non-antibiotic means are usually recommended first. And if they are not responding to these non-antibiotic methods, then only go for antibiotic prophylaxis. And it is reasonable when other more conservative measures have failed. What are different types of antibiotic prophylaxis? First is postcoital prophylaxis. It is appropriate for women with frequent episodes of cystitis that are associated with sexual activity. Another option is self-directed antibiotic therapy, where patient herself starts a short course of antibiotics at the first sign or symptom of a UTI. Such an approach is reasonable if the patient is sufficiently educated about infection symptoms and she will reliably follow all the instructions. If possible, you should obtain a urine culture before starting your antibiotic prophylaxis. Efficacy appears equal to continuous low-dose antibiotic prophylaxis regimens with fewer GIT side effects. If this also fails, then a continuous prophylactic treatment protocol is needed. Long-term low-dose antibiotic prophylaxis is the gold standard method for recurrent UTI prevention, but this is indicated in the most intractable cases where other conservative measures have failed. Intravesical therapy can also be tried, but it is usually done on patients who are on intermittent self-catheterization. They can benefit from periodic intravesical prophylactic therapy. Gentamicin is the most commonly used agent for this purpose. How to manage recurrent UTI when she develops an acute UTI over recurrent UTI? If this happens, you have to obtain a urine culture and an alternate antibiotic agent should be prescribed to treat this infection. Treatment duration should generally be no longer than 1 week. If the urine culture indicates resistance to all available oral agents, you can take help of parenteral antibiotics. Fosfomycin may be an acceptable agent in such circumstances. These are the antibiotic agents you can use for recurrent UTI prophylaxis. The preferred antibiotic agents are nitrofurantoin, SMX TMP, and trimethoprim. The second line antibiotic agents for recurrent UTI prophylaxis are cephalexin, cefaclor, fosfomycin, norfloxacin, and pivamycillinum. But as I said, you have to first try the non-antibiotic therapies, and there are various therapies which are available into our armamentarium. They are cranberry products, D-mannose, methamine prophylaxis, estrogen vaginal cream, probiotics, immunoprophylaxis, and vaccines. Cranberry products, although they are recommended as first-line prophylactic agents, their efficacy remains controversial. D-mannose is relatively costly and the optimal dosage are still undetermined, although 500 milligram twice daily is commonly suggested. Methamine you can try along with the vitamin C. But if the GFR is less than 10 ml per minute, this is a contraindication. Estrogen vaginal cream in cases of atrophic vaginitis. Probiotics can play a very important role as far as recurrent UTI prophylaxis is considered. You can choose the Lactobacillus rhamnosus, GR1, and L. fermentum, RC14. They colonize the vagina and they can subsequently prevent the UTIs. Immunoprophylaxis taken orally may prove an effective alternative to antibiotics. There are various meta-analyses which have shown that if you give immunoprophylaxis with the Urovaxum E. coli extract for a period of 3 months, it is effective in preventing recurrent UTIs. We do have a vaccine, that is MV140 vaccine. It is an oral vaccine for the prophylaxis of recurrent UTI. It has shown good efficacy over 9 years in a preliminary study and is now clinically available in many countries, but not available in the US or Canada. So if it is available, you can consider this vaccine in the prophylaxis. Then there is a fecal microbiota transfer, which is studied for the prevention of prophylaxis of recurrent UTI. Now, just to mention recurrent UTI in pregnancy, screening for bacteriuria is recommended in all pregnant women at their first prenatal visit and then in the 3rd trimester. They should subsequently be treated with antibiotics such as nitrofurantoin, sulfasalazole or cephalexin. Antiprophylaxis for recurrent UTI in pregnant women is effective using continuous or postcoital regimens. Here also the causative organism is E. coli in 80 to 90% of infections. When it comes to prevention, maintaining meticulous personal hygiene, especially in the perineal area, is essential to minimize the risk of bacterial transfer. In women, a thorough evaluation should look for untreated vaginal infections, PIDs, recent gynecological interventions, and prolapse of the bladder, uterus, or rectum. Additionally, you have to check for the use of intrauterine devices. What is the prognosis? Most recurrent UTIs have no long-term sequelae and patients recover fully. Young patients without pre-existing comorbidities have the best prognosis. Patient education should be done at your level because that goes a long way when it comes to the prevention and prevention of the recurrent UTI episodes. Several preventive measures are recommended. They should be advised to keep hydration, topical vaginal estrogens, behavioral modifications, which we have already discussed. So in a nutshell, this is the chart which you all can take a screenshot also. This is the evaluation. When she comes, it starts with history, physical examination. Then you have to do urine analysis, urine culture, and first treat her as uncomplicated recurrent UTI, find out the risk factors. Cystoscopy is rarely indicated, but if it is a relapsing infection, you have to evaluate her with imaging modalities. How to treat her? This is first is behavioral therapy, second is non-antibiotic options, third is antibiotic prophylaxis in the form of postcoital or low-dose continuous prophylaxis. So the key takeaways from my talk are UTIs are some of the most frequent clinical bacterial infections in women. They are less common and are mainly caused by reinfection by the same pathogen. Women with recurrent UTIs, they need to be properly investigated by urine analysis, urine culture, and other imaging modalities if indicated in order to rule out the causes of recurrence, as well as to assess the possible anatomical or functional urinary tract abnormalities. Although standard UTI therapy starts with antimicrobial therapy, alternative strategies are available to reduce exposure to antibiotics, such as use of methamine salts, probiotics, cranberry juice, immunoprophylaxis, and vaginal estrogens. Continuous antibiotic prophylaxis, postcoital prophylaxis, and acute self-treatment are cost-effective treatment strategies for reducing the number of recurrent UTIs in some patients. Thank you, friends. Thank you so much for your patient hearing.
Thank you so much, Dr. Lakshmi. That was a wonderful talk. And there is one question only in the chat box. They are asking for what is the duration of the low dose antibiotic regimen in recurrent UTI?
Continuous regimens, usually it
Continuous.
should not be less than 1 month.
Okay. So, and
Then you have to decide, you have to take a call based on her clinical signs and symptoms and her symptoms.
yeah. So one thing I've just wanted to say that you have stressed so nicely that increased water intake is so important. And nowadays, children, when they are studying all the time or they are sitting in front of the computer screens, so they completely forget to take water. So I always advise these adolescent girls who come with the complaints of recurrent UTI that you must take water and sit. And then even if you are doing your work, you keep on having water. And another thing, that front to back wiping is very important. And plus, I think that I always advise these girls that they should wear cotton undergarments, because otherwise they are very fond of wearing synthetic stuff, and then there's no aeration that leads to recurrent problems. And if the patient keeps on giving history of recurrent UTI, especially after sexual intercourse, then the husband's semen examination should be done, and they should be advised to use a condom. So these
Without
things are very...
spermicides.
Huh.
Ranjana, without spermicides. If
Without
they are using,
spermicides.
yeah.
Yes.
Because that is again a cause, risk factor for recurrent UTI.
Yes, without. And then what you told about postmenopausal use of estrogen creams, that really helps, because I have seen patients who come and they are really desperate. They've had so many courses of antibiotics, but they keep on having these attacks. But once you give them these local application, then it's very relaxing for them. So thank you, Lakshmi. I think it was a wonderful talk with very clear messages.
Thank you, dear. Thank you.
It was an excellent talk, Lakshmi Madam, and thank you for
Thank you,
starting our webinar. I request Dr. Meena Saman Madam to introduce our next speaker, that is Dr. Aparna Hegde.
Good evening, everyone. It's a pleasure to invite Dr. Aparna Hegde for the next talk, which is going to be on urodynamics. So she's Associate Professor, Urogynaecology, Kama Hospital, Grand Medical College, Mumbai, Consultant Urogynecologist, Global Health, Surya Hospitals, Mumbai, and Women's Hospital, Mumbai. She's founder director, CUP, Delhi, founder and managing trustee, ARMMAN, an NGO that works in the field of maternal and child health in 27 states and has impacted the lives of over 60 million. Congratulations, ma'am, for that. And she's chair of FIUGA, chair of Publications Committee as well, editorial board of International Urogynaecology Journal. So we know she's a very accomplished person in the field of urogynaecology. I do remember her visit before the COVID to Patna on the same subject. Ma'am, the floor is yours.
Thank you so much. It's a very, I don't know how I'm going to finish in 15 minutes because it's a huge topic. I'm going to try my best. So please forgive me if I go a little further. 1 second, this opening, I'm just going to get my talk. 1 second. Is it sharing? 1 second. One second. Let me go to the first slide. Okay. So what is urodynamics, right? Urodynamics is basically the study of the, mechanics of bladder, function, like filling, emptying, and voiding in the laboratory. So it's basically the study of the function and dysfunction of urinary tract by any appropriate method. So just don't take a patient to the urodynamics chair, right? First, you have to evaluate the patient properly. I hope somebody's taking a lecture on evaluation of a patient of urogynecology of lower urinary tract symptoms. So you will do a proper examination, you will do a bladder diary, you will do a urine test to rule out infections, all of that. And only after you come to an understanding, okay, I'm looking for this particular pathology, will you take the patient through the urodynamics lab, right? So always do a bladder diary, right? It gives you a lot of information, okay? Now, when you do urodynamics, what do, right? You are putting in a lot of catheters with pressure transducers, right? So you're going to have one in the bladder, one in the abdomen, and then you're going to measure the pressures during filling, exertion, and voiding, right? And that's why it's called complex or multi-channel urodynamics, because you're measuring the pressures in the bladder and the abdomen with multiple channels. It's also called subtractive cystometry. I'll park it for now. I'm going to tell you a little later why it's also called subtractive cystometry, right? Now you can use either air charged or water perfused transducers. I'm not going to say more than that. I use air charged transducers because it really helps me understand urethral pressures. And in dysfunctional voiding patients, it gives me a lot of information because I do a lot of voiding difficulty patients. I like air charged transducers, but you can also use water perfused transducers, which are used countrywide by the urologist, right? Now, you will start the study with a simple non-instrumented uroflowmetry. What does it mean? You'll make the patient pee, and you're going to record how does she pee. So the flow rate, the flow, you're going to see the flow pattern, and the volume voided, right? This is a screening test to select patients for more complex urodynamics. Now, the thing is this, uroflowmetry, like in urodynamics, any other test you do in urodynamics, you have to make it as physiologic as possible. If I tell you in most labs, everybody's talking, you're making the patient pee in a regular room, the bladder is not going to function well. So try to mimic normal, voiding circumstances as much as possible. So in my clinic, if you come, and all my clinics, basically the patient pees in the bathroom, and we're recording by using Bluetooth outside, right? The flowmetry, right? It's a simple flowmetry. And in Kama Hospital, in fact, I also have an Indian, I have the Indian style and the Western style, both, right? You cannot make a woman used to, squatting to pee, use a commode and see that whether the voiding is good or not, right? So uroflowmetry has to mimic normal patterns of voiding. You can most likely, now what is available is weighted uroflowmetry flow meters. Basically, it's a weighing scale on which a jar is placed, on which into which the woman pees. Earlier, there was a rotating disc one, which is actually more accurate, right? So the woman would pee and the disc would rotate, and that would give you the flow rate. But it's not available as much now, so we use the weighted ones. And basically something like that, right? Patient pees on a commode in the bathroom into the jar, and it's recording. There's a weighted jar, right? A weighted weighing scale, which gives you the measurements. And you get a graph like this, right? So your x-axis is flow time, and your y-axis is flow rate, ml per second. And the flow pattern is generally bell-shaped curve, right? So normally you're going to, define whether the woman has got voiding dysfunction based on the Q max, meaning the maximal flow rate. So in females under 50, it's generally more than 25 ml per second. And females over 50, it should be more than 18 ml per second, right? I would look at the flow pattern, and I would look at the Q max. And the Q max is less than 15 ml per second. It's a cause for worry. But the flow pattern is equally important, right? Now, this is like the normal, patient. If you see the top bar, it's the flow pattern. There's a nice bell-shaped curve, a quick upswing and a slightly longer downswing, and the volume voided. Remember that you can only comment on the urodynamics on the uroflowmetry if the woman has voided 150 ml at least. But it depends on the patient's condition. If a woman has got overactive bladder, you cannot push and she's peeing normally 90 ml, 100 ml. You cannot push the bladder to hold 150. That's not physiologic for her. So keep in mind what's her bladder capacity. One other thing I'm going to tell you about uroflowmetry, like in ultrasound to see post-void residual, right? You have done ultrasound to see post-void residual before the urodynamics testing, right? Now, always ask the patient be comfortably full bladder. Never ask the patient be too full. The bladder will never work well, right? She should normally pee in uroflowmetry, or when you're doing sonography for post-void residual, at the volume that she would normally pee. Never ask the patient to drink a lot of water and pee 600 ml, 900 ml when the patient has got overactive bladder, right? So please be very careful. She's going to pee when she's comfortably full bladder. Ask the patient that, right? So that's one take-home message. Even regular ultrasound for post-void residual, normally comfortably full bladder. Now examples, right? This is normal, flow pattern, right? She's got a good bell-shaped curve, and Q max is more than 15 ml per second. Even the average flow is very good. But look at this, right? This is a constrictive flow pattern, right? Look at the plateau pattern, prolonged low flow, right? This is a problem pattern that will make you think that something is going wrong, right? This could be urethral stenosis, or this could be a dysfunctional voiding patient, right? Now, if I have a patient in whom I'm suspecting dysfunctional voiding, What does it mean? A lot of women don't pee well because they've got pelvic floor dyssynergia. Normally, when you void, the pelvic floor relaxes subconsciously. It's a normal part of voiding. The first step of voiding is pelvic floor relaxation. And a lot of patients may have one of the most common reasons for voiding dysfunction is dysfunctional voiding, meaning when they pee, they don't relax the pelvic floor or the urethral sphincter, right? So when they don't have relaxation pelvic floor sphincter complex, then they can have voiding dysfunction, which is a very common reason. You know, when you operated on a patient or she's got bladder pain syndrome and there's pain, right? She's got recurrent UTI episodes, they tend to start squeezing the pelvic floor while peeing. It becomes a habit. In those patients, I will also do surface EMG along with it. So this is a see, look at this, what I see, right? You see the flow rate is in the top row. The flow rate is interrupted flow. You can see very minimal, little void she has. The volume she's voided is less because she's got a voiding difficulty. And look at the EMG, right? I've got EMG that I'm recording. Normally, EMG should get relaxed. When I pee, you see the red bar, this whole red staccato acceleration dysrelations, this is abnormal. When you and I pee and we pee well, there should be silencing of the surface EMG. It should actually narrow. The minute I say, okay, now you pee, the minute I give that permission to pee, the reflex starts, the pelvic floor relaxes. You can actually see the pelvic floor relax. Now, when I see this pattern, that the surface EMG has got staccato acceleration dysrelations, right? You can see the red EMG, right? It's got up and down swings. There are two reasons here. Either she's got pelvic floor dyssynergia, right? That she's not relaxing the pelvic floor, and that's why the voiding is wrong, right? When you don't relax the pelvic floor, urethra will not open up properly. Or this patient may be having detrusor underactivity, meaning the bladder muscle is not working well. Now, in response to detrusor underactivity, oftentimes patients push to pee. And in response to pushing to pee, the pelvic floor will contract. So now I need urodynamics to differentiate between the two. Is this a pure case of pelvic floor dyssynergia leading to voiding difficulty? Or is it a patient with detrusor underactivity? And that's why she's pushing to pee, she's straining to pee. I will know that only when I do urodynamics, right? So I will do a uroflowmetry and then follow that up with urodynamics, right? So I hope you understood uroflowmetry with surface EMG. Now, another pattern, right? Look at this uroflowmetry, right? When I asked the patient to pee, right? There was a whole hesitancy. At the start, I gave her permission to pee, and it took a little while to pee. When the peeing started, look at this, right? The peeing pattern is not bell-shaped curve. You can clearly see. Initially, she pees okay, a little bit, and then there is this staccato interrupted flow. You know, look at that. There's interruptions. And look at the surface EMG. It relaxes. You see the narrowing that happens. It's not relaxed all that well, but it relaxes at the minute the peeing starts. But then she starts having these acceleration dysrelations, which may be responsible for her voiding difficulty. She may also be straining, and that is in response to that, this interrupted flow pattern is happening. Look at another pattern, right? Look at this. Prolonged low flow. If you look at the top bar, the flow pattern is not bell-shaped, it's prolonged low flow. And look at the surface EMG. Look at you see the point I gave her permission to pee. Look at the acceleration dysrelations. You saw that? The classical dysfunctional voiding patient, right? Now, next we will go and do urodynamics. So I take the patient to I will do uroflowmetry in the bathroom or uroflowmetry with surface EMG, and then take the patient to my urodynamics chair. I have a very especially if you come to our Delhi center or your Mumbai center, you will see a urodynamics chair, which I've designed, which allows me to take the patient up to my eye level, to do the urodynamics, right? And we start off, in my clinic, I would do urethral pressure profile first, right? I would do urodynamics, and then I will go, uroflowmetry, and then I will do urethral pressure profile. Urethral pressure profile is a part of advanced urodynamics. So I'm going to park it for now. And most urologists don't do it. I'm going to tell you later on what is urethral pressure profile. The normal standard urodynamics would include uroflowmetry, cystometrogram, and pressure flow study. I'm going to talk about that first. At urethral pressure profile, I'm going to park it for now, right? So like I told you, what is urodynamics is also called as multi-channel urodynamics or complex urodynamics, right? So what is cystometrogram? The patient is now, you've got the patient to do uroflowmetry, then you've done the post-void residual after it, the bladder is now empty. Then you're going to assess the filling phase of the bladder. And that's called cystometrogram, right? Right? Now, when I do the filling phase examination, I'm going to put in catheters, right? So one goes in the bladder. And in my clinic, I not only measure bladder pressure, I also measure urethral pressures. If you go to regular urologists, they won't measure urethral pressures, but we do because ours is a voiding dysfunction center. So we have an advanced center. I have a catheter, an air charge catheter that measures both the bladder pressure and the urethral pressure. So you see this catheter in the bladder. The color coding is just for you to understand. Blue is bladder and yellow is urethral pressure, right? So we get PVES and PURA, right? Then I have a catheter in the transducer in the vagina or the anal canal. I put in the anal canal. You can also put in the vagina. Don't put in the vagina if the patient is going to prolapse. I prefer the rectum. I would put in the anal canal. This is a rectal probe. This is the abdominal probe, abdominal catheter. It'll give me the abdominal pressure, right? P-abd. Right? So I've got the PVES, the PURA, and the P-abd, right? Then I'm also going to attach the surface EMG leads perianally. That is giving me the perianally, and that's giving me the surface EMG, right? So I want to understand how is the EMG working during voiding. And then I'm going to get all the pressures, all the like on the computer screen, I'm going to see all the pressures, right? So the pink one is the bladder pressure, the blue one is the abdominal pressure, the black one on top is the urethral pressure. I'm also getting the surface EMG, right? So you're going to see all these pressures, right? So look at that. I marked out the pink one is your bladder pressure. Then you got the abdominal pressure. Then you're getting surface EMG. And you also, and okay, now there's also the urethral pressure, the blue black one in the top row. Now, I also get the detrusor pressure. What is the detrusor pressure, right? Detrusor pressure is the pressure of the detrusor muscle. Now, it is not measured by the catheters you put in. The computer keeps giving it to you. And how does it give it to you? Imagine you're in the bladder. The pressure on the bladder is that of the abdomen and the bladder muscle, right? It's like the roof and something and the thing above the roof, right? Now, so PVES is equal to P-abd plus P-det, right? You have to add up the two to get the bladder pressure. So then how do you get the detrusor pressure? The computer is continuously subtracting the abdominal pressure from the bladder pressure to give you detrusor pressure, right? Oh God. No time. It's a huge topic to do in 15 minutes. What do I do?
Short, I think, because the time is limited.
I don't know how to shorten my urodynamics lecture. It's one of the
I know
hardest
it's
things.
not a short
You cannot
lecture.
give me I cannot just tell you 1, 2, 3, 4 and
Yeah.
somebody will understand, right? I mean, I think I taught uroflowmetry, I guess, right? So I can't even tell you interpretation until you even know what you're measuring. Anyway, so in cystometrogram, we're looking at the detrusor pressure. So when we're doing cystometrogram, when we start filling the fluid, we fill it at 10% of bladder capacity. And then we record the sensations of first sensation, first desire, normal desire, strong desire, and urgency. And that urgency, the volume that you've filled in, is called as maximum cystometric capacity, right? Normally between 300 to 500 ml. I'm also going to look at compliance, right? When the bladder fills with water, urine or water, there should be no rise in pressure, right? So you're going to, if you look at the detrusor pressure in this graph, if you see the detrusor pressure, green one, it is flat. What does it mean? The bladder is filling, but the pressure is not rising. That's a compliant bladder. The minute you have neurogenic bladder, if you have damage to the bladder muscle, which is myogenic, you will have rise in pressure as the bladder fills. That's called non-compliant bladder, right? So compliance is important to see in a normal patient. Then you're going to look for leaking of urine. You're going to make the patient cough every 50 ml of filling to see if she got stress urinary incontinence, if she gives you a history of that. And you're also going to record, does she have any overactivity? Normally, when the bladder fills, there should be no overactivity of the bladder. Okay, the bladder should not contract on its own. There should be no involuntary contractions. Any involuntary contraction during filling is abnormal, and that's called detrusor overactivity. And it's called leaking of urine along with that. That is called as detrusor overactivity incontinence, right? Very, very important. Now, I also do something called a leak point pressures, right? So the way to look out for stress urinary incontinence is, one, ask the patient to cough every 50 ml of filling to see if she leaks. There should be no bladder contraction, but the cough should make the patient leak. We also do Valsalva leak point pressure. So at around capacity, you'll ask the patient to cough Valsalva 3 times. And if there is any leaking during Valsalva, you're going to see the lowest rise in bladder pressure during Valsalva that leads to leaking. And that is your Valsalva leak point pressure. Very, very, very important. Valsalva leak point pressure, if it's less than 60 centimeter of water, meaning it requires very little rise in abdominal pressure during Valsalva to leak. And if it's less than 60 centimeter of water, that's one definition of the severest form of stress-inducing incontinence called as intrinsic sphincter deficiency, right? So if you've got ISD, intrinsic sphincter deficiency, Valsalva leak point pressure will be less than 60 centimeter of water, right? Next, I'm just finishing in 2-3 minutes. Next, I'm also going to briefly tell you about urethral pressure profile. Urethral pressure profile is advanced urodynamics. We draw the abdominal, the bladder catheter through the bladder and the urethra. And we see the rise in urethral pressure. Because when the catheter comes in the urethra, the pressure will rise. Why? The urethra is a thin tube as compared to the bladder. So you're going to see how much more than the bladder pressure, the urethral pressure rises. And that's your maximal urethral closure pressure. Okay. So urethral pressure profile is a measure of the urethral pressure. And you will see how much more than the bladder pressure, the urethral pressure rises. If the maximum urethral closure pressure, the maximum rise in urethral pressure over the bladder pressure is less than 20 centimeter water, it is another component of ISD, intrinsic sphincter deficiency, right? So basically, if Valsalva leak point pressure less than 60 centimeter water and or maximum urethral closure pressure less than 20 centimeter water, it is called as intrinsic sphincter deficiency. Lastly, I've done the urethral pressure profile, I've done the cystomatogram, then I'm going to make the patient pee, right? And this time the peeing is with the catheters in place. I'm going to see the bladder contracting, is the pelvic floor relaxing, is the urethra relaxing while peeing? Because normally when women pee, they'll pee with pelvic floor relaxation, that was a muscle contraction and urethral relaxation, and they will not strain. There will be no abdominal straining. And you're going to, so the first peeing is without any catheters in place. Second peeing is with catheters in place because you're going to get all of these pressures, right? So in this patient, if you see, she peed by, if you see this peeing, if you see the red peeing, right? The second last row, you can see the voiding. And when she's voiding by good retrosal contraction, and the surface EMG is not increased, right? She's relaxing the surface EMG. There's bladder contraction, the green line. The green line is showing you bladder contraction. The bladder is contracting well. There is no abdominal straining, and she's peeing well, right? So you're going to see how she pees by doing pressure flow study. Lastly, when do you do urodynamics? Okay. In stress urinary incontinence and in urgency incontinence, if the conservative management fails, before you do any advanced treatment like surgery for SUI or any Botox for urgency incontinence, you should always do urodynamics. If the woman has got mixed incontinence, you have to do urodynamics. If the woman has got voiding dysfunction, you have to do urodynamics, right? So any neurogenic pathology, okay, or is recurrent incontinence, recurrent stress incontinence, refractory incontinence, which is not responding to treatment, right? There's a complicated history. Please do urodynamics, right? Always. Lastly, I'm going to show you some graphs and then I'm going to stop, right? I'm going to just annotate and show you. You have to give me 1 day, an hour lecture. 1 day. Yeah. So if you see this graph, right? I know how to annotate. There's no annotation in this. In your Zoom, I cannot do marking. Okay. You see if you see the arrow, those arrows are pointing to the detrusor pressure. And I told you PDET. And I told you then when this is the filling phase. Okay. We are looking at the filling phase. And can you see the small bumps in the PDET? That is overactivity. Okay. And look, that is detrusor overactivity, idiopathic. This is not normal. Look at this green line. In this, it's a busy slide. Basically, this is the filling phase. I'm measuring all the pressures, the urethral pressure, the bladder pressure, the abdominal pressure, the detrusor pressure. Now look at the green line. Just look at the green line, right? This is detrusor pressure. This is a filling phase. Like I told you, there should be no contraction of the bladder muscle during filling. Look at the contractions, right? Such a huge contractions. Can you see those contractions? This is detrusor overactivity. Okay. Now, another one, same patient, right? Look at this, right? Look at the green line, detrusor overactivity, right? This is filling phase and the patient is contracting away, detrusor overactivity. Now, this is SUI, right? The patient has coughed, but is it really SUI, right? So basically, when the patient, when you see the upswing, you see the first, where this leak is written, you see the graph, right? You see the bladder pressure, the abdominal pressure, and you see the quick upswing and downswing because you made a patient cough. When you cough, the abdominal pressure increases and the pressure will rise, right? Normally, when you SUI, there should be no bladder contraction. There should just be a leak along with sudden rise in pressure of the abdomen or the bladder. But look at this patient. This patient is actually not SUI. She leaked with cough, but there was a triggering of bladder contraction. If you see the bladder contraction, if you see the P-dead, this is the third one is P-dead. Look at the bladder contraction that happened. I can't annotate on this. Ideally, I should be able to annotate. Anyway, if you look at the first row and see the upswing and downswing, right? After that, there's actually a contraction. So this is a patient, if you see, there's a contraction. Normally, when you cough, there should be no contraction of the bladder. This is not SUI. She leaked. This is not SUI. This is CADO, cough associated detrusor overactivity. Sometimes coughing can lead to bladder contraction. That is not SUI. That is detrusor overactivity. If you miss this patient CADO and think it's SUI and do sling surgery, you will destroy her life. So urodynamics let you understand, is there CADO? If a woman has got severe leak on cough, you do a lot of coughing and then suddenly you have a very big leak, you must suspect CADO. That actually it's not SUI. The bladder coughing, the contraction is caused by, the coughing is leading to bladder contraction and that is causing the leak. Okay. Lastly, non-compliant bladder. Like I told you, look at the arrow. I showed you the arrow. This is the filling phase of the bladder. Normally, the bladder pressure should not rise with filling. And look at this green line. Look at the rise in pressure. Can you see the rise in pressure? It's not flat. It's rising. It's a non-compliant bladder, neurogenic bladder. There will be kidney back pressure changes. Very, very important to understand. And very last, this is classical dysfunctional voiding. Okay, patient not peeing well. Start from the top row. Urethral pressure. The orange is urethral pressure. Look at when there's a middle blue color. That is uniformity start. I gave the permission to pee. The minute I gave permission to pee, look at the urethral pressure dropping. Can you see that? Top row, the pressure dropped. The minute I give permission to pee, your pelvic floor should relax and the urethra should relax. In this patient, the urethra relaxed. And the bladder contracted. The second row is bladder contraction. The pink line, the bladder contracted. The third row is abdominal pressure. She didn't strain. It's a flat line. And because the bladder contracted, it's showing the detrusor contraction, right? But look at the surface EMG. The surface EMG is staccato acceleration decelerations. Look at that. Throughout the voiding, she's not relaxing the pelvic floor. And that is leading to dysfunctional voiding, right? The flow is not good. It's prolonged low flow. So I'm clear here that that is contracting. The urethra is relaxing, but the surface EMG is not relaxing. This is dysfunctional voiding. And she responds to biofeedback very, very well. This is a patient in whom I will do biofeedback therapy for relaxation. And they will relax and they will do very good. I've got patient on catheter who come out of catheter. The voiding dysfunction patient, because pelvic dyssynergia, respond beautifully to relaxation therapy, on biofeedback therapy. I'm going to show you one last graph if possible. Anyway, I think there is no time, so I'm going to leave it at that because otherwise, okay. Yeah, 1 second. I'm going to show you just one last graph and then we're done. 1 second. 1 second. Monica is going to give you the lecture on voiding dysfunction. This will help you. I showed in the previous urodynamics pressure flow study while voiding, urethra relaxed. Now this is a voiding study phase. Look at the urethral pressure, the top row. Can you see the urethra? The orange line, it doesn't relax well. Can you see that? It's not relaxing. There's like an up and down, up and down, up and down. The first row, you see the pressure. When I give permission to pee, there's no relaxation of urethra. It is actually not relaxing properly. It's coming up and down. This is the patient in whom the bladder contracted. See the next line, the pink line. There's a little bit of bladder contraction, right? And the surface NG is okay. Look at the red bar. It's okay. And if you look at the blue line, there's no straining. But her voiding is very bad. Look at the flow. It's in blue, right? The flow is poor, interpreted. This patient is a patient of Fowler, so-called Fowler syndrome. Fowler syndrome doesn't exist. High tone urethral sphincter. Normally, when you pee, the pelvic floor and the sphincter urethra relax. This is a patient in whom the urethral sphincter did not relax. She was in CIC. She was doing catheterization 5 times a day to pee for last 10 years. This patient would not respond to biofeedback therapy. In her, I did sacral neuromodulation. Sacral neuromodulation is a technique where you put a battery in the back and a lead goes along the bladder nerve, S3 nerve. And that she responded really, really beautifully, and she's peeing beautifully. So when a urethral sphincter doesn't relax, you do sacral neuromodulation. If the urethra relaxes and the pelvic floor is not relaxing, you will do biofeedback therapy for, relaxation. Thank you. Or the pelvic floor. Sorry, long lecture.
Thank you. That was fantastic.
I don't know how much I could cover. It's a very difficult topic.
No, the examples were fantastic. I mean, we wanted to go on and on. So does all the viewers as well. They've asked you to continue. But I think it's a tight schedule.
Yeah.
You said, we need a whole few hours to do your...
Yeah. I think if you're doing any urogynecology, you need to understand urodynamics. I have a whole lot of, you can come to my center to see also if you want. Yeah.
Thank you so much.
Yeah.
If there are any questions, you can answer in the chat box, please.
Yeah.
Meena, Dr. Meena.
Yeah. Good evening, ma'am.
Yeah, good evening. And I had another commitment, so I'm joining late, but I had a privilege of listening to Aparna. And as we know, Aparna, we always love to listen to you.
Thank you.
Yeah. So my best wishes to Dr. Suman Sinha as well as Dr. Kavita. And I think today's conveners, Dr. Meena is here, Dr. Sandeep, and everybody. I think so many people have joined, and that shows that the need of the hour for this certification course. So my best wishes for this again for one more day. And I think this certificate course, what ICOG is doing is an excellent idea where we are able to reach to so many people. And the focus group joins because those who are interested in this will definitely make it a point they join and they learn about it. So thank you once again for the opportunity, and I wish all the best for your webinar. One more day.
Thank you so much for joining and for your visit words. We are really grateful to you. Thank you. So, Sandeep, you can go to the next. Dr. Monica has joined.
Yes, ma'am.
Otherwise, can you do mine, madam? I have to travel. Dr. J.B. Sharma here.
Sir, even my case is in OT. I'm just waiting for my talk only.
So,
mine is only 15 minutes. Actually, I have to travel to Delhi. Then for 1 hour, I won't be able to contact. Just 15 minutes. I don't know.
So, Monica, what do you say? When we take Dr.
Ma'am, I do not have choice. Sir, please go ahead.
So, Dr. Hafizur, can you please introduce?
Mine is only 15 minutes. 15 minutes. Sir.
Okay, sir. Okay, sir. Dr. Hafizur, kindly introduce Dr. J.B. Sharma, sir. If he's here,
and
I saw
my
him.
slides can be played from your end, I send.
They will, yeah.
They all know me, that's fine.
Thank you, ma'am, so much. And I was supposed to introduce Monica and J.B. Sharma, sir. Sir, good evening, sir. So I think everyone know Dr. J.B. Sharma, sir. Sir is head of the Department of Obstetrics and Gynecology at Yashoda Medicity, Indirapuram, NCR, Delhi. And he was former professor and unit head at AIIMS, New Delhi. So sir is very much into the urogynecology, that's what we know. So sir was awarded Dr. B.C. Roy Award by Honorable President of India in 2015, and he had around more than 425 publications. And he's author of this textbook of obstetrics as well as in gynecology and midwifery and obstetric nursing. And sir won Indian Medical Council of Medical Research Award. and he was chairperson of Urogynaecology committee from 21 to 24. So, sir is
thank you, Dr. Afil. Thank you.
Yes, over to you, sir.
So, my slides can. Thank you very much. It's a real pleasure to come on ICOG platform, and thank you everyone, Kavita and all that respected chairperson, Parag Benewala sir, Sheila Mane madam, everyone. So, if my slide can be started from your end, I'll try to finish in certain.
Shreya, please share the.
Yes, ma'am.
So I congratulate the whole team of ICOG for this beautiful and thank you, Dr. Kavita and all that. Yeah. So my topic is autologous facial slings, tips and tricks. Yeah. So we all know that anatomy of bladder has been covered. Its functional storage of urine and excretion of urine. Next, please. And yeah. So next is the slides can be put. Yeah. Next slide, please. So we know the bladder has the function of storage and as well as excretion. And someone is changing the slides, please. Next slide.
Shreya?
No, just, yeah. So we all know that stress urine incontinence is basically complaint of any urinary loss of urine on increase in abdominal pressure like coughing, sneezing, etc. Next slide, please. So the slides can be quickly turned, please. Okay, so we all know the extrinsic sports and intrinsic sports of urethra has been covered in previous lecture, and Dr. Aparna also mentioned it. But levator navi, endopelvic fascia, arcus tendinous fascia pelvis are extrinsic sphincter, while the sphincter of the urethra is intrinsic sports and coaptation of the submucous venous plexus, which becomes poor after menopause. Next slide, please. Okay. Okay, so this is the grading, like, mild, grade 1 is mild incontinence, grade 2 moderate, 3 severe, and grade 4 very severe or even at rest. Next slide, please. Okay. Okay, so epidemiology, I mean, as the age advances, almost 25 to 30% patient may have SUI, and with age, it becomes more, and the childbirth trauma is the main cause of incontinence. Next slide, please. Okay, so in Delhi, we had almost 8 to 9% in Delhi clinics, and during pregnancy, we observed 19% in second trimester and 21% in third trimester. Next slide, please. Okay, so treatment normally, surgical treatment is usually required for stress urinary incontinence, but initially for mild to moderate, non-surgical treatment in the form of lifestyle changes, reducing weight, pelvic floor muscle training, bladder drill, and biofeedback can be tried. But later on, we can do the various surgery like colpo suspension, sling procedures, needle suspension, anterior colporrhaphy, peritoneal injection. Next slide, please. So others will be covered by my other colleagues. Yeah, so surgical treatment usually burst colpo suspension is done, and then we can do the same by laparoscopy also, and temporary tapes are to be done. Next slide, please. But some colleague will be discussing that. So my topic is mainly rectus fascia sling surgery, which I'll be discussing. So these are the Next slide, please. It's already covered. And so next slide, please. Yeah. So these are the basically other treatments, also laser treatment, radio frequency, but they don't work that well. So usually surgical treatment is required. Next slide, please. Okay, so before surgery, we have to evaluate the patient. We have to confirm the diagnosis, and then we have to offer surgery. Initially, we may try urodynamic study has already been covered. I mean, when it's to be done for mild to more for normal clear-cut case of SUI, urodynamic studies are not indicated, but it may make sense before doing any tape surgery or sling surgery. It's better to do urodynamic studies and for medical legal reasons also. So that will confirm the stress urinary incontinence. Next slide, please. Next slide, please. Okay, so this is the MMK operation, burst colpo suspension operation are done. So now pubovaginal sling surgery was done in the old, in which we use the patient's own tissues. Right? Okay, because if you are using mesh, artificial mesh, that can cause erosion. So next slide, please. So autologous fascia, I'll be discussing rectus fascia and fascia lata. Next slide, please. Okay. Next, Next slide. So autologous slings are to be done. Yeah. So current mid-urethral slings came into big vogue, but because of the mesh erosion issues and the American College and RCOG gave warning against that. So we can use the sling surgery. They have a cure rate of almost nearly 80%, and they may have little bit of short-term complications and long-term complications, but generally they are safe techniques. Next slide, please. But the mesh erosion is the main issue with the artificial meshes. So with the rectus facial sling and patient's own tissue, that can be reduced significantly. So autologous facial slings are coming back. They are very effective, and they studies on patients with previous failed surgery and significantly reduced incontinence. Almost 50 to 100% improvement was found in 65% patient, and slight reduction in rest. So they have very high success rate. Next slide, please. So next slide, please. Okay, so this is the diagrammatic representation that the mid-urethral sling is going, and we are sending into the mid-urethral up to the anti-rectus sheath. So we can say that we take 8 into 1 centimeter rectus sheath is cut, 8 to 2 centimeter from the rectus sheath, and then we measure it, and then on either side we put 2 Prolene sutures on it, and then we, from above we open the abdomen, and then in the cave of Ridges viewer, can we put a clamp from above, and then someone will feed that. I'll send a put a clamp from above, and they'll perforate the membrane and then come out, and we make a vertical incision on the vagina about 3 to 4 centimeter in size, and we separate the vaginal mucosa from the urethra, and then I'll send the clamp from above, or we can use the TVT needle also. So ultimately, this sling will be what we have cut the rectus fascia. So this will be used as a mid-urethral sling in the mid-urethra, and it will be tied to the rectus sheath until you can say there. Next slide, please. So ultimately, that mid sling will sling like, or we can use the TVT needle also. So next slide, please. Yeah. So we can say the same thing, and we can see the tape here, and don't make it too tight, so we can use an artery forceps underneath it. So ultimately this is and then we tie to the anti-rectus sheath using sutures there. So ultimately this, just like a TVT, it will sit in the mid urethra. So it has got very high success. Next slide, please. Yeah. Next slide, please. So in our experience, we had done about 38 or 40 cases roughly. So that was, yeah. And then the post-operatively, we can go back to the previous slide. So that was the rectus fascia sling. So alternately, we can use, these are the various needles. We can use the tensor fascia lata also. So for that, we can use the TOT needles can be used for that. So what we do, using the help of the our plastic surgery department or surgery, we take using fasciotome. So we take rectus fascia sling, that means about 8 into 1 centimeter rectus fascia sling is harvested, and then we put 2 Prolene stitches on either end of it, and we put the tape into saline and hydrocortisone and gentamicin solution, and then using these 2 TOT needles, we on either side, we put the rectus fascia, this tensor fascia lata, and through the obturator foramen on either side. So instead of using like artificial mesh, we are using patient's own tissue, that means tensor fascia lata, just like TOT. So rectus fascia, we are using like TVT, using TVT needles or clamp, and here we are using TOT needles, and we are putting middle to lateral or lateral to middle, either way you can use it, and using the TOT needles. Next slide, please. Yeah, next slide, please. So, yeah, so you can see, so that we have put this tape from lateral to middle, and then it is coming on either side through the obturator foramen. So just like TOT, and we are putting an artery forceps underneath the tensor fascia lata, so that we don't make it too tight, and it is coming out through on both sides through the obturator foramen. So just like TOT, instead of artificial mesh, we are using the patient own tensor fascia lata. And then we can take a stitch at the lateral end of the sheath on either side, or we can leave it like that also. So the only thing, the success rate is slightly lower, but if you put the suture there so that it will remain tight, then the results are slightly better. Next slide, please. And then we keep the catheter for about 72 hours. After 72 hours, we remove the catheter. If patient is able to pass urine, patient goes home. So these are the complications. Overall success rate for sling procedure is almost 80%. Long-term success rate is also almost 72 to 94%. And traditional method, it was there. And then there can be short-term complications in the form of like bladder injury, continued voiding difficulty, overactive bladder symptoms, and of course wound, seroma, UTI. Long-term complication can be in the form of voiding dysfunction, overactive bladder symptoms, procedure failure, and incisional hernia. Next slide, please. Yeah. Next slide, please. Yeah. So this, Yeah, okay. So this is the study we published in basically comparative study of autologous facial sling and post-surgical incontinence in the European Journal, and then we also published our editorial on it in Jogi Journal that autologous facial slings have come back. Initially they were there, but then the artificial slings came, and then they went into disrepute. But now because of the mass erosion problem and ACOG warning and US FDA warning and RCOG, so the autologous facial slings have come back into big vogue. But only problem is that the training of them is lacking. So we need to train. We give the thesis topic at AIMS, and we try to train our fellows in this. So then and like maybe the Foxy can take a cue, ICOG can take a lead in that. So we can do workshop, and Dr. Monica is there, and other colleagues, Dr. Parna and Kavita and all that, Amita Jain. So we can help in that. So maybe Foxy and ICOG can do workshop in North India, South India, West India, different cities, major cities, where we can train the local gynecologist and urogynecologist or vessel in this harvesting the fascia and how to use it in this thing, because initial training is required. Next slide, please. But overall, the results are very good. It is free of cost. The patient's own tissues are used. There is no chance of mass erosion. Success rate is very high and all. And so other results also there. Though burst colpo suspension can also be done, but the studies have proven that hand-on that colpo suspension as well as facial sling, they give almost equally good results. So we are still using burst colpo suspension. That also we are not using any mesh, and that can be done. Like if we are doing abdominal hysterectomy for someone, then we can combine birch with that. But if you are doing vaginal hysterectomy for someone, then we can combine TOT with that. But usually now we are using either rectus fascia sling or tensor fascia lata. So rectus fascia sling we are using for TVT, while tensor fascia lata we are using at TOT. Next slide, please. Okay, so I'm about to finish. Next slide. Okay, yeah. So these are the various studies, and 5 years. This thing is also there. So synthetic slings. My topic was up to here only, so I can stop here, because the other topic of artificial sling will be done by my colleague. So I just reiterate in last 20 seconds that rectus fascia sling and tensor fascia lata, they are the patient's own tissues which are free of cost. We can use TVT needle or TOT needle. Success rate is almost 80 to 90%. Only thing, the initial training is lacking, because most hospitals are not doing it. So if ICOG and basically Foxy take a lead, and all of us colleagues in this today's program and Kavita Banwal can take a lead in that, so we'll be happy to train the younger gynecologist in TOT and TVT using rectus fascia sling or tensor fascia lata. They have a good scope. They are free of cost, very friendly to the consumer, and the complication rate are very minimal. Only thing, initial training is required. Thank you very much. So we can stop the presentation, and any question I'll be happy.
Very practical, I think workshop would have been a better thing in this, because it was a beautiful in your own sheets.
Yes, madam. Yeah, that's what I say. That's because in lecture it is very difficult to explain this. No, so
Yeah,
but yeah, we could.
so video also, sir. Video would have sufficed. How you are inserting
yeah,
the tape.
okay, ma'am. Thanks.
Thank you so much, sir, for that.
Yeah, we are trying to make video. Maybe we will share that with the ICU.
Yeah, yes. So, Dr. Sandeep, for the next speaker, we can have some chairpersons from the next session also to introduce Dr. Monica.
Dr. Hafizu sir is there?
Yeah, he was there, but I don't see him now.
Yeah,
I'd love to introduce Dr. Monica Gupta. She is professor, Bardhaman Medical College, Safdarjung Hospital, Delhi. She is a fellow Urogynaecology and Pelvic Reconstructive Surgery. Her specialty
unmute Dr. One minute. Please unmute Dr. Bharti Maheswari, madam. Okay, Meena, go along.
Okay, and she's editor ICOG, Foxy ICOG book, National National Recording, Foxy book, and so on. She's also the coordinator nodes on Foxy Food and Drug Medical Legal 2020, and various awards to her credit. ICOG Traveling Fellowship, and she has authored many books and chapters. So over to you, Dr. Monica.
Yes, ma'am. I'll just share my thank you for the introduction, ma'am. Let's proceed with the academics. Let me just share the screen. Can you see my presentation?
Yes. Just make it full size, that's all. Yes, okay.
So once again, good evening, one and all. My topic is voiding dysfunction in females, how to evaluate, diagnose. So much has been told about, told by Dr. Aparna in a beautiful way of how to, eventually objectively diagnose voiding dysfunction. Let's see what further is required to reach up till that stage and actually, think about a female would be having a voiding dysfunction if she walks into your practice, your clinic, your OPD. How would you suspect that? Okay, so definition which is mentioned in the literature, validated by international urogynecological societies world over, and especially the International Continence Society, is that female voiding dysfunction is an abnormally slow and or incomplete micturition based on abnormally slow urine flow rates and or abnormally high post-void residuals, ideally on repeated measurement to confirm the abnormality. And one must remember that it actually refers to a spectrum of urinary difficulties that impact the ability to efficiently and comfortably empty the bladder. Fine. And as the word suggests, a literal meaning is also voiding dysfunction. So something to do with, inability to pass the urine normally. Okay, so we have to be very careful about these symptoms, which are, known as lower urinary tract symptoms, as defined by the International Urogynecology Association and the ICS. Uh, on your left are the voiding symptoms, which is pushing or straining to urinate, spraying stream, weak stream, post-void dribbling, intermittency, incomplete emptying, or hesitancy. And on your right are the storage symptoms, which include urge, urgency, loss of sensation of urination, involuntary passage, then frequency, nocturia, pain or discomfort, and incontinence. So as we can see, basically these storage symptoms and voiding symptoms can occur in exclusion as well as an overlap whenever we are evaluating a patient of voiding dysfunction. So we really need to be very careful in taking a very comprehensive history and of course the investigations to eventually term the patient as an exclusive, a storage dysfunction patient, which includes overactive bladders and detrusor hyperactivity or impaired contractility, or typical avoiding dysfunction exclusively, which includes bladder outlet obstruction or detrusor underactivity. So women presenting with only storage symptoms, we really need to be very careful. Like if a patient walks into your OPD, says, I have urinary incontinence, and you are evaluating incontinence, but at the same time, you must pay attention and spend some time in taking a very elaborate history in finding out if at all. You can ask leading questions as well, and you have to really evaluate that she might not be having an overlapping voiding dysfunction symptom as well. As regards the problem statement, voiding dysfunction accounts for around 2.7 to 23% of general population, with a significant impact on quality of life. And this is what is the, the newest thing on board. We are actually there to treat the quality of life impairment of the patients, not the anatomic abnormality, right? And amongst the available the symptoms being presented by the patients, most common symptom in avoiding dysfunction patient would be terminal dribbling or feeling of incomplete bladder emptying, followed by weak stream. So I'll not go into detail now to paucity of time about the anatomy and all aspects. We have just a reiteration that, we have an internal urethral sphincter and an external urethral sphincter, in which we must know that internal urethral sphincter is basically is a physiological and a non-anatomic sphincter, and it is not under our voluntary control. It is under autonomic control. And the important thing to know about external urethral sphincter is that it is under our voluntary control, and it is constituted by circular striated muscle fibers. And in accordance with the anatomy is the innervation as well. And we must know that when the detrusor is contracting, the urethral muscle is relaxing. And as you can see, there are sympathetic innervation which is inhibitory to detrusor and at the same time stimulatory to urethral muscle. Whereas when the detrusor is relaxed, that time that is the filling phase, that is the time when urethral muscles are supposed to contract so that they can hold the urine inside the bladder and not let the patient be incontinent. So we must understand that the micturition reflex is under the control of pontine micturition center, and there is this interplay of these neurotransmitters which keep the physiology of the bladder intact, and there is a coordination of the central and peripheral nervous system for normal urinary voiding. As you can see on the right, during the voiding phase, a command is sent to the bladder through the spinal cord, through the pelvic and the pudendal nerves, where the detrusor muscle is contracting and the pelvic floor or the external urethral sphincter is relaxing, and this results in normal voiding. So having understood this mechanism is actually a very important aspect in understanding the management of the patients presenting with voiding dysfunctions. When we come down to classification, as I said, the two major reasons for voiding dysfunction are detrusor underactivity and bladder outlet obstruction, which could be neurogenic, myogenic, psychogenic, idiopathic, and amongst the outlet obstruction causes, it could be anatomic or functional. And we can have a combination of two as well. While further evaluating, we really need to, while evaluating the patient, we really need to pay attention to the previous, neurological conditions which the patient may be suffering from. And having a voiding dysfunction can be just a part of that larger neurological involvement. Similarly, when we are evaluating bladder outlet obstruction cases, especially in our gynae aspect, we really need to pay attention to other abdominal pathologies like, ovarian cyst, retroverted uterus, fibroid uterus, then pelvic organ prolapse in which cystocele, rectocele, and large prolapses can lead to voiding dysfunctions. There can be neoplasias in the genital organs, which really need to be ruled out. So it's not just the typical aspect that the patient says, I'm not able to pass urine well, and you just concentrate on the bladder. You have to evaluate the patient as a whole, and all these points are very important to be taken in the history. When you ask her, and she will present with a classical symptom of straining or use of abdominal pressure to initiate or complete voiding with interrupted urine stream or poor flow. She may be having a feeling of incomplete evacuation of bladder, and she says that I need to sit for prolonged periods on toilet seat, or sometimes need to stand and then evacuate my bladder. And you have to make a note of onset, duration, severity, and triggering events, which could be, infections in past, and very common in females, the vaginitis. And as I had earlier said, overlap of presenting symptoms is very important to be noted, because this really tailor-made, it really tailor-mades your management. And you have to be very careful of recurrent UTI in the past, any bowel dysfunction, past pelvic, abdominal, or spinal surgery, mode of deliveries, intake of medication, or neurological symptoms. Then coming to the evaluation specific, of course, voiding diaries are very important in any kind of urogynecological case being evaluated, which is a frequency volume chart, which gives a lot of information about how the patient, physiology is. She can have small voided volumes. She can have, she can write that I take so much time to void. She can write that I drink so much, but I'm urinating. You can have an idea that she may be retaining a lot of volume. So all these things are made clear through voiding diary. Then we have various validated questionnaires, which we all know. We should now make them as an important part of our evaluation in any urogynecological case. In the examination, mental status of the patient needs to be evaluated, her cognitive function, mobility. Is she grossly obese? Does she have edema due to any other, aspect and any other pathology? Her gait abnormality, which might lead to restriction in mobility, and she may be retaining large volumes and not voluntarily passing the urine. Okay. Then coming to abdominal examination, we really need to rule out retention of urine, which can be simply suggested by an enlarged bladder. You just put in your hand and you find the retained bladder there, mass. And you have to differentiate it with the palpable other pelvic masses, which require further evaluation, especially any masses involving the urogenital organs. While doing a pelvic examination, we have to take care that there may not be any structural lesion like extrinsic mechanical obstruction of urethra, which may be caused by a urethral diverticulum or urothelial malignancies. Then any extrinsic compression by any gynecological malignancy or a benign disease like prolapse. Assessment of pelvic floor tone. Tone is very important, as you must have heard what Dr. Aparna had told you, that hypertonic pelvic floor is one of the very important entities which we people miss. And the similar lines, we need to find out whether the patient is having any tender points or nodules or myofascial bands, which is very important aspect of myofascial syndrome in females, and that can lead to voiding dysfunction. To complete the examination, a complete neurological examination is also required, where we check the intact neural pathways, especially the S1 to S4 components, and those can be judged by bulbocavernous reflex, lateral sphincter tone, and ability to contract the anal sphincter, and of course, perineal sensation. Coming to lab investigations or otherwise, the investigations for voiding dysfunction, urine analysis is our good old friend, or any which way it gives an initial idea about the infection or the state pathology which she might be having. When we go for ultrasound or even MRI, maybe as an advanced evaluation procedure in which we can rule out bladder stone, bladder wall thickness and configuration, we have to evaluate the pelvic floor as a whole. Translabial and perineal ultrasound can give you an idea about the dynamic compression of urethra. As I said, MRI may be required in advanced cases when you are wanting to rule out any neurological involvement in your case. And PVR is a very important aspect, which is post-void residual, as it is a part of the definition as well. So we must know that less than 50 is normal and greater than 200 is absolutely abnormal. Between the two is a gray area, and we have to judge the patient on an individual basis. And PVR is very easily can be calculated through the ultrasounds. Otherwise, we can just simply, after the patient has voided, maybe we can simply do a feeding tube catheterization or a Foley's catheterization and see if there is any other urine which is coming out. Okay, and then is the urethral calibration, which gives you an kind of an objective idea. If you are able to pass a 14 to 18 French catheter easily through the urethra, then at least we are sure that we are not dealing with a urethral stricture per se, which is bladder outlet obstruction. Then comes cystoscopy, which should be ideally done under anesthesia, because we might have a component of an overlapping symptom in bladder pain syndrome, where there's a lot of pain which patient experiences. I'll just take 5 minutes more, which she might, experience. In bladder pain syndrome, it's advised that if you are thinking that way, it should be done under anesthesia. And also, it will differentiate between functional voiding dysfunction and the true urethral stricture. It can also assess the true bladder capacity and give us an idea about diverticuli, urothelial growths, or bladder stone. And if indicated in the same setting with the cystoscopy, a bladder biopsy can be taken to actually rule out a histopathological, give us a histopathological diagnosis. Then comes this very important investigation when we talk about urodynamics. As Dr. Aparna had said, start with non-invasive things, which is uroflowmetry. And it is recommended to confirm the flow pattern by non-invasive uroflowmetry to rule out a test-induced phenomena before diagnosing dysfunctional voiding on basis of UDS findings. This is a very important aspect. Don't just keep advising invasive urodynamics to your patients. At least have an idea, which is a simple, she sits on the commode and just passes urine there, and there is a pressure arrangement, and pressure measurements come through the volume avoided through a funnel, and there's a recorder which gets transmitted to your software. And we must understand that normal flow rate on uroflowmetry along with low residual urine generally excludes voiding dysfunction. So we really need to objectively evaluate the patient. And this is the graph which Dr. Aparna has also shown you, a typical, a bell-shaped graph, which is peaking and then, coming down normally. So as a whole, even if you do not know much of urodynamics, which actually really requires training, you can just simply see this kind of graph. If it's there, you are kind of rest assured in your mind that, okay, I may not be dealing actually with a outflow obstruction or something. In this one, as you had said, that, it is a prolonged graph, prolonged void time on uroflowmetry. So maybe a plateaued or a long-tailed graph. This should alarm you that we are dealing with some or the other kind of voiding dysfunction, which really needs to be evaluated. And this is the typical sawtooth pattern in which patient strains, then voids a little, then stops, then strains again, voids a little. So this is a very typical of, a bladder outlet obstruction, and that may be accompanied with large post-void residuals when she's not able to actually empty her bladder fully. To corroborate and to eventually differentiate between various types of functional bladder outlet obstruction, you might have to subject the patient to urodynamic evaluation further, which may be invasive. And this gives you an idea of the associated neurological conditions as well, like detrusor sphincter dyssynergia, where you had seen those EMG patterns in your previous lecture, and non-relaxing sphincter with spina bifida. So these are the things which you must know are important to actually make the diagnosis of voiding dysfunction. And when you come down to values in your mind, you just should have an idea that a persistent, low, non-invasive maximum flow rate less than 12 milliliter per second on repeated study, combined with a detrusor pressure at maximum measured flow rate of more than 20 centimeter in a pressure flow study, is very much, and in fact diagnostic of voiding dysfunction. And it is mentioned in the literature and all the guidelines that pressure flow study is considered to be the best method to assess the voiding phase of micturition cycle. So let's leave that. Let's not go into detail. And a word about urethral pressure profilometry. Though it is not very commonly done, only done in very research centers and very advanced urodynamic centers, but then even wherever it is done, we must understand that a urethral high maximal urethral pressure of greater than 100 centimeter water may indicate hyperactive sphincter or pelvic floor. So we really need to make those patients relax their pelvic floor before actually going on to any kind of invasive management. And in case we do not have facility of video urodynamics or avoiding phase fluoroscopy, a simple micturating cystourethrogram can give us an idea about the same thing which we are wanting to evaluate, though it has a disadvantage that a co-interpretation of the bladder physiology cannot be done in this kind of test. So this is also in the armamentarium of evaluation of voiding dysfunction. And this is in nutshell how we should be actually evaluating a voiding dysfunction. So I guess that is all what I have to say. And yes, management was not part of this. That will take another long lecture. But if you can take home from this lecture, what you must understand is a thorough evaluation. Whenever a patient walks in, please spend some time in taking a detailed history of all the urogynecological symptoms and the lower urinary tract symptoms possible with a systemic approach. And of course, selection and interpretation of investigation modalities should be done very carefully to avoid wrong diagnosis. The urodynamic traces interpretation requires special training. So, to read between the lines beyond convention. So I would recommend those who are interested in urogynecology, as already told by Dr. J.B. Sharma sir, you're most welcome to, reach out to any one of us for this special training. And as high quality evidence is lacking at present, therefore treatment must be targeted to individual requirements. Thank you for your patience hearing.
Well done, Monica.
Hello.
Sandeep, please call for the next speaker because we are already late.
Yes. So I request
The person, and you want to
Dr.
comment to Dr.
Bharti
Monica?
Maheshwari. Dr. Bharti Maheshwari, madam, is there?
Yeah, I am there.
Madam, please introduce our next speaker, that is Dr. Apurva Bipin Pancholi. Nilima, please share the slide up.
So, Monica, your talk was very nice. Excellent. Thank you, ma'am.
So,
Talks are very nice.
our next chair is Dr. Bharti Maheshwari.
So, good evening, everyone. And first of all, you all congratulations to all ICOG team as well as Dr. Sandeep and all team coordinating. And as we are going to have a very important session in the next session that is related to hypermobility of urinary organs, and that is speaker is none other than Dr. Apurva Vipin Pancholi, and he is a renowned urogynecologist, Associate Professor of Obstetrics, Gynecology and Reproductive Medicine at University of Texas. And he has done his fellowship in the urogyne, and he has done her post-graduation from Florida and has lots of experience in the urogyne. So we are all keen to hear Dr. Apurva Bipin Pancholi. So over to Dr. Apurva.
Thank you so much. I want to congratulate the ICOG team for putting this wonderful meeting that we're having. Everyone has been a wonderful speaker. So I joined yesterday's session on prolapse. Today is on incontinence, and it's just amazing. All the talks. We just finished Dr. Monica's talk when voiding dysfunction was fantastic. Aparna had a great talk. So I'm going to take a few minutes to talk about my topic today. I'm going to share screen if that's okay.
Yes, sir.
And is everyone able to see my slide okay?
Yes, sir.
Okay, great. So I'm going to talk about a topic which is the non-surgical management of urethral hypermobility. And I congratulate everybody putting the theme together of incontinence on today's day. And so, initially when you look at this topic and be like, okay, urethral hypermobility, what are we dealing with, then the first thing we always think about is, stress incontinence. So it's a topic, which could be part of the prolapse talk also, because, it is a prolapsed, part of that urethra that is causing the symptom. But most of us deal with the treatment and everything, associated with urine incontinence that we deal with on this. I will say that, even though this seems like a very basic topic, it's a very, very challenging topic also because this is one of the toughest patient, especially if they come in and they say, I feel a bulge, but they don't want surgery, then to take care of this part of the bulge on the urethra is very, very difficult, especially if it's a difficult patient who is not satisfied with the results, some of the non-surgical treatment options. So I'm going to go ahead and start. So what is the definition of urethral hypermobility? So urethral hypermobility is basically the downward movement of the bladder neck and the urethra with any increased abdominal pressure. So bending, squatting, lifting, coughing, sneezing, anything that leads to increased abdominal pressure, which would then reflect on the bladder neck and the urethra, moving further out of towards the introitus. So just like any form of prolapse, it's a reflection of weakness in the pelvic floor and the connective tissue. And yesterday's talk, we learned about the anatomy, and we talked about, what forms the pelvic floor. It's the muscles, the connective tissue, the nerves. And so all of them actually play a role in this weakness, happening. And just like I mentioned earlier, that this is something that is associated with stress urine incontinence. So when we hear about urethral hypermobility, we always think about stress urine incontinence. And we don't know the exact mechanism of stress urine incontinence, but we think that it's a spectrum from anywhere that's between the urethral hypermobility to intrinsic sphincter deficiency, which is just a weak urethra, no matter where it is anatomically. But most of the time, ISD is not the main cause. It's the urethral hypermobility. It's the hypermobile urethra which cannot maintain the same pressure that's generated because it's out of the abdominal cavity now because it's hypermobile. And so when the bladder pressure goes up, the urethral pressure does not equally go up, which leads to then stress urine incontinence. So this is an important diagram. This shows all the support structures, specifically the ligaments in the pelvis. So a lot of them are, on the screen, but I want you to mainly focus on the pubourethral ligament, the one with the star. And you can see that that one is the main support for the urethra. There are other structures that are associated with the support of the urethra. There's external urethral ligament, which is the distal, very distal urethral support. And then again, the main part is also coming from the pubocervical fascia. And we all know that, the urethral hypermobility could be associated with any anterior compartment defect. But the main one is the pubourethral ligament. And as you can see, even the way, the structure is, it's the weakness in this, the ligament or a tear that, would lead to the urethral hypermobility. And when we do our surgical treatments, i.e. our slings, that we just heard Dr. Sharma talk about, or, or any kind of, suspensions that we do, birches or anything like that, we're basically putting stitches or, surgery in the same area to lift things up. So now, why are we talking about this? Why, why is it, relevant? And so the most, it's most commonly, the mechanism for stress incontinence. So that's why we're always, dealing with this, because stress incontinence is so common. But it's also associated with difficulty emptying bladder. It can be, causing dyspareunia, pelvic pressure, just, patient feeling like there's something right at the introitus. It does, as we talked about earlier in both today and yesterday's talks also, it impacts the quality of life. So that's the main thing. Dr. Monica just mentioned, that we're not just dealing with the anatomical defect, but we also are dealing with the quality of life. It also affects the social functioning that's associated with SUI, and then it also impacts the body image of a patient. Patient is not going to feel good having to wear diapers if there's a, at any age, actually. Shouldn't be at just older age, but at, any age, that's not the right thing. So it's very important that we address this. How is the urethral hypermobility diagnosed? I know that most of us have been taught during our clinical examination, we should be performing a Q-tip test, where a Q-tip is placed in the urethra, and more than 30-degree urethral rotation is what we call a positive Q-tip test, which would then, justify the diagnosis of urethral hypermobility. But that's a very uncomfortable thing for the patient also. So if you think about it, POP-Q is, an exam where we look to see, we take measurements, and point AA on a POP-Q is something that's, 1 centimeter already a deflection. So that 1 centimeter is a 30-degree deflection. So a POP-Q stage 1 or greater also will be, diagnostic for urethral hypermobility. Also, we saw earlier, in some of the talks, you can use ultrasound to make a diagnosis of urethral hypermobility if you can visualize it and take measurements, and then based on that diagnose that. Also, the history. What are the patient's symptoms? Is the symptom associated with SUI, which again I alluded earlier, that's the most common one, or prolapse symptoms, or pain or discomfort or anything like that. Urodynamics is something I know it's very important, and in bladder function, but it's not something that's required for diagnosis of urethral hypermobility. So you can definitely use it for voiding dysfunction, for to confirm SUI, to look at urethral pressures, and you can even use it to determine your treatment options. But is it required for the diagnosis? The answer is no. Okay. So let's talk about the non-surgical management options. Lifestyle modification is always the very basic thing the patient can do. Pelvic floor muscle training, pessary devices, energy devices, topical vaginal estrogen, and something that's still investigational because just, there's still studies that are going on, and there's data on both sides of the treatment, which is stem cell therapy. Okay. And then, so what are the conservative managements? So weight loss, just 10% weight loss can help improve bladder function or prolapse symptoms up to 30 to even 40%. So weight loss is very important, something that we should address and, guide our patients to see what we can do to help them. Caffeine reduction, smoking cessation. Smokers absolutely immediately need to stop smoking. Not just the other health benefits, but for the bladder also, it is something that's critical. And then there's bladder training and behavioral therapy. That's also very important. So let's talk about pelvic floor physical therapy. The International Continence Society and so many other medical organizations recommend PFPT or pelvic floor PFMT, pelvic floor physical therapy as the first line treatment for SUI. And it's because it's low cost, it's low risk, and it's been proven, in efficacy also. So when you strengthen the pelvic floor, it helps stabilize the bladder, neck, and the urethra, which then counters that downward movement. And so when that pelvic floor is stronger, there's less chance of incontinence. There's a Cochrane review that looked at 31 randomized trials and showed that pelvic floor PT was significantly 8 times more likely to report a cure, 6 times more likely to repair at least improvement compared to placebo. The only issue is that there's a wide range between 28 to 80% in the cure rates, and the variability is because of there's different training protocols. Different physical therapists in different parts of the world are using different protocols to treat certain things. There is some basic things that they do, but then there's also differences. So the other thing is, we're all familiar with mechanical devices. So there are so many mechanical devices that can be used. They're non-surgical, and they can be used to elevate the bladder, neck, and the urethra. So pessaries is something that has been used for centuries. We all are very familiar with that. They're mechanical devices. They come in different shapes and sizes. And studies have shown that urine incontinence has resolved in anywhere from 20 to 83% of patients. The problem with pessaries is how many people continue with pessaries. So the numbers are anywhere between 16 to 57% of people continue using it past 1 year. And it could be for so many different reasons. Patients don't want to keep coming back for evaluations. But the advantage of this is pessaries are very reversible. If they want to stop using it, they can stop using it, and there's no harm done. It's not like a surgery that you cannot go back on. There are so many other mechanical devices on the market. They're a good option for somebody who is bothered by stress incontinence only during specific times. So if somebody says, when I go and do my dancing, or, if I go to, go visit a sports game and I'm cheering or something, or anything like that, and at that time I'm losing urine, but otherwise I'm totally fine, then it might be a good option for her to try something which is a mechanical device that she can herself put it in during those times and then remove it. And so it's a good option, if for somebody who has stress incontinence or even minimal prolapse. It does require the patient to have good dexterity to be able to put it in, take it out. It also is very important that the patient has good mental function. This is not something that I would recommend for my 80-year-old patient who has dementia. And because what if she forgets that she has it in there? The family is not going to know about it, and then you can end up with severe consequences due to that. So it does require that the patient, any device that you're putting in, the patient has to have good cognitive function also. It does slightly increase the risk of UTI also, and there's always a chance that it can cause some dysuria or skin irritation, especially when the urethra is elevated. The passage of urine could be uncomfortable, and if that's the case, then they need to be refitted with a different device. Then there's also energy devices. I know we have heard about this, and we have some talks on this also in this conference. So really looking forward to all that. There's lasers, radio frequency devices. They all kind of work through heating, the controlled heating, then which promotes the new collagen formation. So that collagen formation will then decrease the bladder neck and the urethral mobility. And so this is another non-invasive treatment option, and it's there's no recovery, there's no downtime or anything like that that we deal with, when we see surgeries. Finally, there's estrogen. There's, vaginal estrogen, even though we don't talk about this, but I put this here because it improves collagen synthesis. We also know that it improves the blood flow, which then increases urethral closure pressure. There's studies that show that. And so from this, they can have improved SUI symptoms. There's improved sexual function. The only thing is there's really no data on the urethral hypermobility improvement with vaginal estrogen. So, sorry I had to rush in the end, but I wanted to finish on time. And I want to take a minute to especially thank Dr. Suman, Dr. Kavita, and again, the whole ICOG team for inviting me and for allowing me to be part of this conference. It's, like I said, it's really amazing. The topics that you all have chosen are just fantastic, all of them. And the speakers and everybody, it's a great learning experience for everyone. And I look forward, you all have my contacts. So, I think our next step should be that we should start doing, collaborations and research and, opportunities and allowing, to put our minds together so we can do even better things.
Thank you so much.
So much topic.
Excellent talk.
Excellent talk. Excellent.
Innovative, yeah, innovative things.
Yeah. Dr. Bharti, can you conclude? See there.
Dr. Bharti, madam, are you here? I don't know.
Okay, so we'll move fast because we are already getting.
Okay.
Vidya madam.
Vidya madam, what from you?
Hello,
she's
it
Vice
was a
President
really
elect.
excellent, Dr. Apurva. And you explained so clearly and clear take-home message. We are very happy about it. And I don't think any questions are there in the chat box or any queries. And virtually we could listen to you. Really, it is great. Thank you very much.
Yeah. I really appreciate it. Thank you.
Thank you
so much. Thank you. So we'll move to the next. So Vidya madam, can you introduce our next speaker, Dr. Ragini Agarwal madam?
Madam,
it is always a pleasure. I think Dr. Sandeep told me to introduce Dr. Meera. Is Dr. Ragini there? Just check her whether she's there.
Vidya madam, Meera madam is there.
Yeah. So I will introduce Dr. Meera.
Yeah, she had some. Yes.
She's there. No, Ragini also joined. Okay.
I have joined.
So you decide whom I should introduce.
JB Sharma, Monica, everyone I have decided.
No, you just tell me because whom to introduce first. You decide whether Dr. Meera or Dr. Ragini.
I think Dr. Meera.
Meera is first, then Ragini madam.
मेरा इसके पहले है, अपूर्वा के बाद मेरा ही टॉक है.
अच्छा, ठीक है. Dr. Ragini, you are very well known to everyone. And so many credentials for Dr. Ragini Agarwal. We know that she is so active in various fields, I must say. Fellow clinical gynec endoscopy, and she is so many. You can see her CV on the screen. So I will just tell her about the president of Indian Society of Aesthetic and Regenerative Gynecology.
Yes, madam. But then
and so many awards, so many publications, and she has edited so many books. And she is my very dear friend and past chairperson of Food, Drugs and Medical Surgical Equipment Committee, and also my guide also. So over to you, Dr. Ragini, for your talk. We are eager to listen to you.
Thank you so much, Vidya, for the kind words, and thank you all the chairpersons who has remembered me for this prestigious ICOG course. Suman and Kavita, thank you so much. And Dr. Sandeep is all the time in touch. So not wasting much time, I will go forward with the blessing of God and the gratitude to one and all. I'm going to talk about the energy-based devices and adjuvants in the stress urinary incontinence. It is an emerging therapy in the urogynecology. So here there's a confusion. We are not replacing any standard therapy, but to evaluate minimal invasive innovation, which has an effect on the patients, specifically when you cannot offer any surgery to the patient in the early stage, but she's suffering her quality of life is not good. She needs some treatment. Here, this is a gap between the conservative treatment and the surgical treatment, which is fitting with the regenerative medicine. We have listening this epidemiology of SUI. We all know what it is, involuntary leakage, and global prevalence is very high, underreported due to the stigma, and more common in the multiparous and the menopausal women. And not only why it is a serious health issue, because it affects the emotional, physical, and the financial health of the woman, and it is very necessary to offer them some treatment, at least when you cannot offer a surgery and or the conservative measures are failed. So it has impact on the SUI, embarrassment, social withdrawal, sexual dysfunction, depression, and no doubt there's a lots of cost is also there. And today the adult pad market is too high than a children pads diaper market. So we are seeing what are the first line treatment from the PFMT to lifestyle modification to the pastry to bulking agent and all type the surgery. There's just the JB sir has also told a very nice surgery. Does Trilextine has a role in the SUI? There is a little bit doubt, yes, but people are saying it may have an effect or may not have an effect. Then PFMT is really very, very long. Everybody can't affair. Kegel is not a PFMT. Please forget the Kegel. Kegel is itself is not something very favorable exercise with all the pelvic floor rehabilitation physiotherapist. Surgery is effective, but there's invasion, complication, mesh has gone, going really gradually out and out, and bulking agents, they are costly and they are also short term. Remember it, they are also short term. So we are here to find out some bridging options. So patient expectation is low downtime, minimal invasiveness, high safety. And then women fall into the treatment gap because for PFMT, sometimes it is not possible to go to the physiotherapist and it is not really controlling it if a patient is having a mild to moderate one and maybe she is at milder level, she doesn't require any surgery also. What we do, we just offer a Kegel exercise. Here, energy-based therapies and the regenerative injectables really have a role. So these therapies aim to restore tissue integrity and continence by enhancing collagen, vascularity, and the neuromuscular support. So what we have in our hand, when we talk about the energy-based devices, they are radiofrequency lasers as a carbon dioxide laser, erbium laser, although some people are using diode laser, but again, how effective they are, there's a question mark. Then people call it HIFU, but the real term is a microfocus ultrasound. We are not giving the high intensity ultrasound, which is leading to the tumor destruction. Then we have a biological adjuvant as a platelet-rich plasma and the other regenerative options like stem cells and the exosomes. The pathophysiology of SUI have been discussed in a detail, and we all know that the continence depends on the both structural support and the sphincter function. Childbirth trauma and the estrogen deficiency accelerate collagen breakdown, and these changes make the urethra unable to withstand intra-abdominal pressure. Now we should remember a few things: collagen, elastin, and extracellular matrix. These things in general we don't focus, and this connective tissue degradation is the real central pathophysiology. Collagen provides tensile strength, elastin provides stress recoil. Elastin is only formed in the fetal period, although collagen is formed whole life. That's why we always say neocollagogenesis. We never say neoelastogenesis because nobody can form elastin afterwards. But yes, collagen can be modified and collagen can be neogenesis can be occurred in the collagen. So with the menopause, there's a hypoestrogen. With the decreased collagen, what happened? The collagen type is changed from the 1 to 2 to the 5 type. It has a less strength and decreased vascularity. When there's a weak extracellular matrix, at that time there's a poor urethral closure. So this energy-based therapy, what it does, it does this control thermal energy, lead to collagen denaturation to the remodeling if it is less than 42 degrees centigrade. If you go above the 60 degrees centigrade, it will be totally denatured and you cannot remodel it again. This stimulates fibroblast, there's a new collagenesis and improve tissue firmness, vascularity and restore urethral support. Why adjuvant? Mostly we are all using platelet-rich plasma, although there are a few studies from the stem cell system, but everybody is not using the stem cell. Stem cell has a much better role than the platelet, but we are very happy with our platelet-rich plasma. It is an autologous concentrate of the growth factors PDGF, VGF, TGF beta, and it also enhances angiogenesis, ECM repair, stem cell recruitment, and injected periurethral improves sphincter function and potential as a regenerative injectable. Really, this one talk can I have a complete 3 days conference on this. So when we talk about the regenerative adjuvant beyond PRP, there's a stem cells. They can be adipose-derived, muscle-derived satellite cell. It is better not to use the hemopoietic cells-derived cells, stem cells. And as far as the cord blood cells is concerned, it is not going to give those the cells which we require for these adult therapy. We are not going to get from the one packet of the cord blood cells. The scaffolds are coming up. It is a tissue degradable, biodegradable tissue-like structure, and it gives a strengthening like a elastin to the structure, to the extracellular matrix and collagen gels. And early trials show the potential in restoring the sphincter contractility. It is still in the research. Then what we have in our hand is a radio frequency, that is monopolar and the bipolar, lasers, carbon dioxide, RFM fractional, and microfocused ultrasound. Each device works differently at a different penetration, but common endpoint is a collagen remodeling. So what happened? There's an electromagnetic spectrum, and these lasers have a different wavelength, and that different wavelength has a different capacity to go inside the epidermis and or mucosa up to the dermis, or only the microfocused ultrasound can go up to the lamina propria. But again, although carbon dioxide laser, its depth is less, but it make a channel down by its heat penetration. So RF is a heating to 40 to 45 degrees centigrade, collagen contraction and the new synthesis. And carbon dioxide laser is a microablative. What we are using today, it is not the ablative lasers and the wound healing and the collagen repair. It is aseptic wound formation, which which leads to the wound healing, and in that way the collagen repair and collagenesis occurs. And this micro-focused ultrasound is a deep focus hitting without epidermal damage and all induced tissue remodeling, but the depth and the effects differ. So if you see this slide, which shows how this cell activation lead to the heat shock response and the all healing process. And when we talk about the carbon dioxide laser beam, which I normally use, it causes a aseptic wound, and it will finally, it is a repair occur because of the wound healing. And it is a nano beams which go inside. One laser beam form a 81 nano beams, and this is a pixel technology. Radio frequency devices, they are in the market as a non-ablative single or multiple session, and 60 to 70% subjective improvement in the mild and the moderate SUI. It is the most patient-friendly, although all are, I think, patient-friendly, outpatient, painless, no downtime. But its durability is little less than the lasers. When we talk about the micro-focus ultrasound, the most beauty of this particular gadget is that it could target the pubocervical fascia more effectively than other energy-based devices. But it is newer, less widely studied than the radio frequency and the lasers, which is in the market almost for last 15 years. So coming to my favorite device, that is the carbon dioxide vaginal laser. It creates a microthermal zones, stimulates collagen, improves mucosa thickness. This is the first laser which has come for the menopausal DSM cases around 2010 in the market with the name of the Mona Lisa. And it was found that it is effective in a SUI therapy also. Although FDA issued caution due to the lack of long-term RCT, although FDA has given a permission to do the conization, vaporization of the cervix and the vagina inside with the carbon dioxide laser, but they have not given the permission to work on the surface. Then another thing is the erbium YAG laser, which is non-ablative photothermal effect. This is a gentle heating versus a carbon dioxide ablative mode. Although in my own practice, and none of the patient has any problem with the carbon dioxide laser. The problem is that people don't use the proper carbon dioxide laser machine. They go for the cheap Korean and the Chinese model. So basically, when you don't give a proper energy in a directed way, then the problem creates. And marketed as a safer due to the non-ablative mechanism, but long-term durability of the erbium YAG laser is really unclear. How the laser affect? There's a photostimulation, photodynamic reaction, and the photothermolytic reaction. If you see this mechanism diagram, it is it has a work on the cellular level, on the mitochondria level, and laser light. It is there's a release of the ATP, ROS, and the nitrous oxide, and lead to the neocollagenesis and the neoangiogenesis. What happened when the laser goes inside? There's something called chromophore. There's like a sponge. In the vagina, it is water, and when we talk about the blood, it is hemoglobin, and when we talk about the hair reduction, it is melanin. It absorbs the laser, and some energy is scattered, and some energy transmit even the deep level. So when we see the comparison, the mechanism is thermal and ablative in the carbon dioxide. Depth RF is very shallow. Carbon dioxide makes the micro columns, and erbium YAG is also superficial. RF doesn't do anything. Erbium YAG could. Carbon dioxide, FDA says caution, but in my practice of the 12 years, I have not seen anything related to the carbon dioxide laser, which I can say it can cause. Even last 30 years, we are using carbon dioxide laser for different things on the ward removal and everything. We have never have any problem with the carbon dioxide laser. So what is finally, if you introduce any therapy, you want a clinical outcome. So we have all no RCTs, mostly they are the small studies, and almost 60 to 80% in, they say the subjective improvement. Durability, again variable, 12 to 18 months. Some patient comes in the 8 months only, come in the 1.5 years also. And there's a heterogeneity in the studies. So what actually we require lots and lots of the cases along with the RCT. Safety profile is almost they are safe if you have a real FDA approved good machines with you, but there might be a transient burning. I have never experienced. Discharge, yes. Mild edema, yes, it can cause, because this is the mild edema. It is inflammation which leads to the basically the injury which leads to the collagenesis and the neogenesis. Scarring, pain, worsening syndrome is a very rare thing. Safety is good short term, but unknown beyond 10 to 15 years, because it is in market last 15 years, and we need a registry based data collection. Now, as far as the regulatory perspective is concerned, FDA has warned, but IUGA is somehow started talking about the carbon dioxide lasers. Indian guidelines, no formal endorsement. So you have to tell the patient in the black and white, listen, there's no backing of any regulatory bodies. It is a new treatment, and I'm giving you this treatment. If you are ready, only then I'll give you this treatment. This thing is a wonderful thing. Wonderful thing, this electromagnetic chair. And you just sit on it, and it basically what it is a type of a PFD, pelvic floor exerciser, and increased blood circulation. Even RCOG also said For these things, you need a pelvic floor exercise. So adjuvants PRP in SUI, they are derived from the autologous blood, centrifuged to concentrate platelets, contains more than 30 bioactive proteins, and it is a biological regenerative tools and being used left and right in the orthopedic dentistry and the dermatology. Double spin centrifugation versus commercial grade. We use the double spin centrifugation. Variability in the platelet concentration, the lymphocyte content. Yes, sterilization is lacking in the most of the places. So there's the importance of technique. You should have to master your technique, how you are going to do it. And there should be a neat guidelines to ensure reproducibility, which is still not there. Mechanism of action is there. The growth factors will stimulate fibroblast proliferation, angiogenesis, stem cell recruitment, and enhances urethral sphincter strength. It also promotes true tissue generation, unlike bulking agents. Bulking agents does not cause any regeneration. It is just made a pressure on it when we introduce the bulking agent. So we give it the periurethral, even you can give the transurethral submucosal. There's a lasers specifically from the erbium laser, which go inside the urethra and do the laser, and they that particular machine claim to for this a good effect in the SUI. What we use basically with the laser, we use this PRP, 2 to 3 ml PRP injected the multiple side. It is an outpatient local anesthesia, quick, safe, and repeatable. Clinical studies, mostly trials say 60 to 70%. Some objective PET test reduction. Today only I had done the laser of an elderly woman, and she said she has almost stopped urine leakage on the sneezing and everything. She was very happy. So, but a small and the promising trials are there. Limitation is a small number and the lack of the RCTs. When we talk about the PRP versus bulking agent, bulking is a mechanical effect. PRP is a biological regeneration of autologous safer. Cost, although PRP injection and the bulking agents, no doubt it is very, very costly. When, although somewhere, some places they say it is comparable, but most of places in India it is comparable. It is not comparable. Bulking agents are very costly. It is not even available easily. PRP offers more natural regeneration and both may require repeat session, but PRP has better biocompatibility. Safety, absolute safe.
Ragini madam, we can finish, madam.
Yeah, and there's
because we have already 5 minutes more, Ragini.
Listen, मेरा भी 15 minutes नहीं हुआ है, मेरे 12 minutes हुआ है. टाइमर लगा रखा है,
टाइम अप होने टाइमर लगा हुआ है.
हाँ, 5 minutes बचे हैं, मेरे पास भी 3:42 बचे हुए हैं. So there's a compare. ये पहले जिन्होंने ज्यादा बोला है और ज्यादा बोल के उसको बैन नहीं देने वाले हैं.
नहीं, आपका तो सुनते रहना है, लेकिन
वेरी लिमिटेड टाइम. मैं अपनी ओपीडी के बीच में से टाइम निकाल करके बात कर रही हूँ.
अच्छा,
there's a combination approach, RF and the laser session followed by the PRP injection, and it reported the greater improvement. The main thing, you have to select your patient. You cannot give all the patient is having a severe degree, and you do the this laser and PRP and you think your patient is going to be happy. Not going to be happy at all. So contraindication is pregnancy, infection, malignancy, and the coagulopathy, and you have to go the safety screening. Patient counseling is must. You have to be very fair with the patient. Documentation is very necessary. Cost effectiveness 15,000 to 25,000 is the PRP. Energy 40,000 to 60,000. Complete package. Some people can take per cycle, but we take the complete package. So compared to surgery, surgery is one-time procedure. Long-term cost benefit is unclear, and you have to be medical legal and ethical aspect clear. Take a documentation, take a consent properly. So when we talk about, to summarize, energy and a PRP is a promising but experimental. I don't agree. Experimental we are doing for last 10 years and having a good result. Yes, in mild SUI, it's only it is working. Unlimited long-term RCTs, summarize finding neutrally. There's a lots of gaps in the research because basically the small sample size. There's no guidelines still available. We have to make some guidelines, and stepwise approach is always good when we talk about the SUI. Yes, we can offer in the mild SY where we cannot go for any operation. So there's a future of regenerative gynecology in the form of the stem cell therapy, exosome treatment, combination, and the personalized regenerative care. To conclude, SUI remains a significant unmet need. Energy-based therapy and the PRP are promising. Evidence is evolving, and as a specialist, our role is to balance enthusiasm with evidence, innovation with safety. Let us continue to explore research and the responsibly integrate these modalities into the practice. Actually, it's broaden our armamentarium in the SUI management, and now bulking agent pharmacological aids serve this role, while regenerative methods like PRP and the stem cell hold the promise of longer-term tissue restoring solutions. So these are the regenerative solutions in the SUI, which we are using with the energy-based devices in the PRP. Bladder leakage or urinary leakage is common. And if you struggle with the bladder leakage, you are not alone. Only you have to say this to your patient. Energy plus regeneration is the future for the SUI care. It is about identifying that the therapeutic gap where traditional treatment either not enough or not desirable. Regenerative tools step in where we need symptom relief plus tissue healing. Thank you so much for the question.
Absolutely brilliant talk, and it is out of your experience. You have put your all the slides were so nice and so self-explanatory. There are only 2-3 questions in the chat box. If you can answer them
Yes,
there
I
only,
can answer. Yeah,
you
please
can
ask.
answer them. Thank you very much, Dr. Ragini.
अच्छा उसमें मैं वहीं पे आंसर कर दूं आप कह रहे हो?
Yeah. Only some PRP injections, how often they can be given. Okay. So I have a pleasure to again introduce our next speaker, Dr. Meera Raghavan, who is a senior consultant urogynecologist and robotic surgeon, proctor and trainer, Hugo RS at Robotic Platform, convener of TNFOG certificate course of urogynecologgy, and board certified lifestyle medicine physician. So many credits to her, and now she will be talking on intravesical Botox in the management of overactive bladder. Tips and tricks. Over to Dr. Meera.
Thank you, ma'am. Thank you, ICOG, yet again for this lovely opportunity.
Your slides, yeah.
My topic is intravesical botulinum toxin, mainly which is used in the management of overactive bladder. So we all know that the overactive bladder is accompanied by urinary urgency with frequency, with or without leakage, depending on whether it is a dry or a wet overactive bladder. It is definitely an impact on the quality of life, and it reduces the quality of life and the independence, and definitely patient confidence. It can be neurological, it can be idiopathic or secondary to some other cause within the bladder. So it's important for us to figure out what it is. It disrupts work, sleep, and social activities, causes significant anxiety and depression for patients, and they're embarrassed even to talk about it. Not only that, in elderly people, we treat continence because we are worried about the risk of fall.
Sorry
And
to interrupt you, ma'am.
Ma'am,
Here says not the slideshow. Slideshow.
Not moving also.
Make it slideshow, Meera.
Okay. It is on slideshow here.
Ma'am, click on the from beginning.
Okay. Sorry about that.
It was not moving also. The slides were not moving.
Now?
Yes.
Yeah. Thank you.
Move your slide.
So come here.
Yeah.
So the first slide management is about having lifestyle modification, basically bladder training and fluid management. Then we have our medical therapy. Though it is intercalated here as a third line management, it is for refractory cases of OAB and for patients who have neurological bladder or neurogenic bladder. Though most of our guidelines do a stepwise approach, like our LNG IUS, which has been used for abnormal uterine bleeding, from a second line, it has now become the first line of choice It will not be long in the future before botulinum toxin also becomes a first-line management, because imagine a patient suffering with urge incontinence. It does not come with notice. It does not give you warning. It happens suddenly, and patient is embarrassed, has to change multiple times, or has severe rashes and restricts water intake and develops UTI. And imagine the number of tablets the person has to take for a long period of time. So botulinum toxin will be a definite welcome intervention for this patient who is suffering from such a severe problem. So what is intravesical Botox? It's injection of botulinum toxin type A into the bladder wall for patients refractory to oral medication, blocks the neurotransmitter releases and reduces the bladder overactivity. It can be either done as an outpatient under local or general anesthetic, and frequency is repeated every 6 to 12 months. So how does it basically work? It inhibits the acetylcholine and other neurotransmitters in the bladder nerves. It can be reducing the urgency, frequency, and the incontinence. And the duration will last into a year or even 18 months. And 6 months most likely for a neurogenic bladder. The target here is the actual detrusor muscle, which is overactive, and the sensory endings of the nerves, which are inside the bladder innervation network. And it has a robust clinical evidence supporting its usage in clinical practice. So who are the patients who can be indications for intravesical Botox? When they have failed oral medical therapy, patients with multiple sclerosis and spinal cord injury, there has been no identifiable cause within the bladder for such a causage, or for those averse to daily pills or develop complications with the pills, and third line medical therapy. So there has been significant reduction in urgency, frequency, and incontinence. It increases the maximum bladder systometric capacity, reduces the detrusor pressure, so there is no unprovoked involuntary detrusor contraction and a big gush of urine which is coming there, effective where medications failed, and effective even in pediatric patients, especially with neurogenic bladder. So with the evidence, it has been shown that it's causing high satisfaction with symptom relief, improvements in daily activities and emotional well-being. Repeated injections do continue to maintain the benefits. It's not like tachyphylaxis or getting adapted to the medication where patients do not respond well to repeated injections. It does not form something like an antibody response. So, but however, between two injections, a minimum gap of 3 months is required, and superior to placebo in refractory cases, and recommended by major urological and continence societies. How is the safety profile? Very common side effects can be UTI, because we prick the epithelium at multiple places during the injection. 1 in 10 can develop urinary retention, and therefore we educate the patients and also counsel them about a possibility of a need for prolonged catheter for about 10 days and for need for clean intermittent self-catheterization. Very rare complications can be hematuria because of any hemorrhage when we are pricking the bladder, and bladder pain. Very rarely systemic effects. The 2 patients where I would exercise caution while introducing intravesical botulinum toxin are patients with myasthenia gravis, because it can potentiate the myasthenia effects, or avoid aminoglycosides, which potentiate the neuromuscular relaxation effects while putting the Botox. Risk factors are patients who are elderly, frail, and those with comorbidities. Monitoring will need checking how they are voiding after the botulinum toxin injection and checking the post-void residual volume. If the post-void residual volume is less than 150, they're good to go home. How do we manage these side effects? Urinary retention is by catheterization, and we teach them self-catheterization as well. We always give prophylactic antibiotics and prompt recognition of the symptoms of UTI treatment accordingly. Bladder pain can be managed with antispasmodics and analgesics, and we also give them regular patient education leaflets so they understand what is in store for them. So comparing Botox in relation to the oral medications, we have the medications in terms of antimuscarinics, which are the solifenacin and the darifenacin types, or the fesoteratidine as well as the tolteratidine. And we have the beta-3 agonist, which is the mirabegron. Now, Botox, often superior in refractory cases, differ between treatments and varies based on lifestyle and patient tolerance. So comparing both of them, injection into bladder wall probably every year, whereas oral medications have to be taken daily. Definitely similar or superior to oral medications, more likely to eliminate symptoms. Good, but there is a small risk of retention and UTI. However, anticholinergics are also at risk of causing a urinary retention and a UTI. Treatment burden, it will be less frequent, higher per procedure at the outset, but because of the less frequency, avoidance of daily medication, the cost of the medication and the cost of the continence device, in the long run, Botox will prove to be cost effective and cost beneficial for a patient who's on long-term therapy. So highly efficacious in refractory OAB, increases the capacity of bladder more than the medications. It is better for severe symptoms and is definitely recommended when initial treatment fails. We've already looked at the side effect profile. What about those adverse effects? About urinary retention, 1 in 10 can require catheterization. Urinary tract infection can happen 1 in 15 because of the incomplete emptying. Difficulty urinating may be an initial side effect but gets better after a week. Very rare to have dry mouth, constipation, cognitive decline, loss of memory, blurred vision, which are all potential side effects of the commonly used anticholinergic medications, i.e. solifenacin or darifenacin. They have to be used with extreme cautions in elderly patients. Otherwise, there is a significant evidence of cognitive decline in these patients. So it has to be done with utmost caution. So Botox, as I said, every 6 to 12 months. Some prefer lesser frequent injections, does not rely on daily compliance and may reduce daily hassle. Cost consideration, higher per procedure, but less frequent, may decrease with Botox as the incontinence supplies are not needed and increases the cost if there are UTI and other procedures. This is just to give an overview of all the available therapies and how Botox fares in the ladder of treatment. As you can see, it can be done as an in-office procedure or under GA. So it has high patient satisfaction, good symptomatic relief, better patient side effect profile, and good safety. Who do we select? Refractory OAB, neurogenic OAB, and patients who are not willing to take any further medications. Outpatient setting or general anesthesia, I use a cystoscopic guided into detrusor muscle in 20 different areas in a template fashion. I go from above and come down below. If I come from below above, there will be bleeding. I will not be able to see the bladder properly. Duration hardly takes 10 to 20 minutes. Patient gets 2 voids measured. After the second void gets post-void residual measured, if it's less than 150, you can discharge the patient on the same day because you've done it under antibiotic cover and bring them back in 2 weeks for checking for uroflow and post-void residual urine. So as I mentioned, we would have already taught them self-catheterization and complication recognition and proper education of the patient as what to expect. Repeated injections are mainly required in neurogenic bladder. In neurogenic bladder, the reason for botulinum toxin is to increase the bladder capacity, decrease the bladder pressure, therefore negating the pressure effects on the kidneys, thereby saving the upper tract. The use of Botox cannot be more than emphasized in the neurogenic bladder because it is a saving measure for the upper tract. And it's just not for the management of incontinence because it helps relieve the pressure and the back pressure on the kidneys is thereby negated. So we can postpone the effect on the kidneys or save the kidneys from the back pressure. Side effects, we've already gone through this. And we have now longer acting or lesser invasive options available. Botox, as I mentioned earlier, is due to become a first-line therapy provided our patients are well counseled and educated and appropriate patient selection. So in summary, highly effective for refractory OAB, the drug of choice for neurogenic OAB, mainly to protect the upper tract, very safe with monitoring for side effects, superior to medications but invasive, cost initial outset higher per procedure but less frequent recurrent costs, and very high patient satisfaction, especially when symptomatic. This is just a video for everybody to view so that you can understand how easy and reproducible this particular procedure is. And it is the mental block which many people have, that it is an invasive procedure. It is definitely a welcome intervention, especially for elderly women who are not able to wear diapers all the time. It's about their dignity. It's about their self-embarrassment. It is about the rashes, the intertrigo. So many problems. You'll have to sit and talk to an elderly patient who suffers from incontinence. It is actually heart-wrenching because the quality of life issues are never explored in the business of a health practitioner. So this is the diluting method. We take 10 ml in each syringe. I take 3 syringes. First, you have to realize the fact that the botulinum toxin is a lyophilized powder, which is a freeze-dried powder, and you take it under sterile precautions. You do not agitate the powder. You pull the plunger, allow the diluent to go in under negative pressure as if it's sucking in. So first dilute it. As you can see, you don't force the plunger. You allow it to go by its own negative pressure. So the entire powder is mixed with the diluent. You do not make it frothy. You do not make it foamy, because then you can miss out on the powder being diluted and constituted properly. You just roll it like you do a swiveling of your wine glass. And similarly, the powder gets incorporated into the diluent. You take 2 ml of this, dilute it with further 8 ml. That makes 10 ml in each syringe. I also concurrently use this for the pelvic floor injection as well. If they have a pelvic floor spasm, especially in patients with neurogenic disorders, this can be happening. As you can see, this is an overactive bladder. It's got multiple trabeculations. Trabeculations are a feature not of obstruction. Trabeculations are a feature of detrusor overactivity. That is why the patient gets severe incontinence. We put in a Cook's needle through the side channel, and we are able to directly see the epithelium and then inject. This is to show the Cook's needle. My assistant will keep pushing 1 ml per bleb. I choose the detrusor as well as the submucosal area. So alternatingly, I choose an intradetrusor injection and a submucosal injection. When I inject the botulinum toxin, you can see the bleb raising up. That is suggestive of the injection gone into the submucous plane already. As you can see, it will balloon up like a jellyfish. So we go around in a template fashion in around 20 to 30 points, and that completes the procedure. And the last 1 ml, I flush it so as to avoid any dead space accumulation of the botulinum injection. I do not waste even a drop because this is pretty dear. So it will cause the patient this problem with the therapeutic benefit. So thank you for the opportunity. That completes my presentation.
That was a wonderful presentation, Dr. Meera, and so nicely. The last video was excellent. Only one question they have, that whether we have to avoid trigone area. As you told, you are injecting from
a trigone area. I do it in patients who have bladder pain syndrome, because the usual teaching is avoid trigone. But in bladder pain syndrome, the trigone has a plethora of nerves, and bladder sensitivity is the main issue. So trigonal injection will definitely help. The place to avoid is nearer the ureteric orifices. That will cause a bit of reflux problem otherwise.
So any complications of this Botox?
The only thing we need to look out for because of retention or for UTI. But we are doing it under antibiotic cover, and we will make sure patient voids and a post-void residual done, and that should not be circumvented.
Yes.
Thank you very much. It was a wonderful talk. Thank you.
Thank you.
Quickly to the next session.
Thank you, Vidya madam,
Thank you.
for nicely conducting this.
Thank you all ICOG and mainly Dr. Suman, Dr. Kavita, everybody. Thank you very much.
Sharmila madam is there?
Charmila is very much there.
Yes, ma'am. Our next session chairperson is Dr. Charmila Ayavu. She is the director of Aditi Hospital and Ayavu Fertility Center, Trichy. She is the vice president Foxy 2024. So the next chairperson is Dr. Kavita Singh. She is ex-HOD Department of OBGY, Jabalpur, Madhya Pradesh, and she is very very much interested in colposcopy training. And she had a very good experience of teaching experience of around more than 25 years. So I invite both these chairpersons for this session. And Ayavu madam, please invite this next speaker, Dr. Kavita Barnwal madam. Hello. Charmila madam?
Hear me? Can you hear?
Yes.
Yes, madam.
Yeah. Thank you so much, Dr. Sandeep. I'd like to thank the convener for the day, Dr. Suman. It's my honor to introduce our next speaker, and that is Dr. Kavita Barnwal. She's going to talk on bladder pain syndrome, the diagnosis and management. She's a chairperson of the Urogynaecology and Pelvic Floor Repair Committee of Foxy, an associate professor at Dr. Buddha Koshi Medical College, Garsa, and she's a recipient of the Padma Bhushan Kamla.
Thank you, madam. Thank you for your kind words. So should we start? Will you allow me to share?
Please start.
Yeah. Let me share. Yeah. Are you able to see slideshow?
No, ma'am. Click on the slideshow, ma'am.
We can see your slides, but not the slideshow.
I have put, madam.
From yes.
Not in slideshow yet.
Is it
now
visible?
Yes. Now it's there. Now it's there.
Okay. River chairpersons, seniors, friends. First of all, I would like to thank the organizing team ICOG for giving me the opportunity to talk on bladder pain syndrome, which is very arduous topic, and I think stepbrother of overactive bladder, which has been well explained by Dr. Meera. So what is bladder pain syndrome? Let's see with a case. This 32-year-old woman presents with a 7-year history of severe suprapubic pain with urethra burning and urinary frequency. She describes her pain as achy, burning, and gripping. Her daytime frequency is 14 to 18 with nocturia averaging 4 volts. She has constant urgency, hesitancy, slow flow, and experiences significant dyspareunia. Cultures have always been negative. Before this referral, she has visited so many doctors, serologists, gynecologists. Her treatment history included antibiotics, urine cleansers, painkillers, but she has not got relief. And what is the provisional diagnosis? Most likely interstitial cystitis. So this interstitial cystitis or painful bladder syndrome is a chronic debilitating condition characterized by pelvic pain, urgency, and frequency in the absence of infection. The Society for Urodynamics and Female Urology defines this syndrome as an unpleasant sensation, maybe pain, pressure, discomfort, perceived to be related to bladder, associated with the lower urinary tract symptoms of more than 6 weeks duration in the absence of any identifiable causes. The term interstitial cystitis was first described by Skinny in 1887, who mentioned about the destruction of mucous membrane of the bladder by inflammation. Lurie Hunter, a Boston gynecologist, first time in 1914 described a symptom complex of bladder pain associated with a unique cystoscopic finding of mucosal lesions, the elusive ulcer, later termed as Hunter's ulcer. J.P. Borok from Canada used the term painful bladder in 1951. The prevalence is exactly not known, mostly underdiagnosed, but it's found that in US about 60 per 1 lakh, Europe 20 per 1 lakh, Japan 3 per 1 lakh, and India is supposed to be 52,500 per 1 lakh women. Mostly women, 90% cases, median age is around 40 years, and India has minimum 1.25 million patients with bladder pain syndrome or interstitial cystitis. Chronic pain, discomfort with bladder filling, and relief with emptying is the hallmark of the interstitial cystitis, and pain is most important thing, accompanied by at least one lower urinary tract symptom such as persistent urge to void or urinary frequency. Other symptoms sign like pain during intercourse, low backache with bladder filling, increase in symptom during menstruation, pain, pressure, discomfort of the suprapubic area, urethra, vulva, vagina, rectum, or lower abdomen, as well as back. It is found that in 70% cases, interstitial cystitis is associated with endometriosis, while in 10% interstitial cystitis is found alone, in 20% both these are, endometriosis is found alone. Etiopathogenesis is multifactorial. No single theory is an explanation of this interstitial cystitis syndrome, but the accepted theories are mast cell activation, epithelial dysfunction, neurogenic inflammation, and central nervous system sensitization, gag layer damage, urinary tract infection, signaling disturbances, decreased tight junction proteins, autoimmune disorders, psychosomatic factors, high urothelial permeability, and there is some afferent plasticity as well as pelvic floor dysfunction, that is hypertonic pelvic floor. These theories or these things lead to thinning of the bladder endothelium with increased permeability, and there can be small pinpoint bleeding and sometimes bladder wall ulcer, that is called Hanna ulcers. Increased permeability can lead to leakage of the urine solids into the urothelium with increased nerve growth factor, interleukin 6 and histamine. CNS nociceptors are also stimulated, and these further lead to inflammation, hematuria, especially in presence of Hanna ulcer, and pelvic pain. So most accepted theory is abnormal gag layer, which allows penetration of potassium-rich urine, causing stimulation of pain receptors and other inflammatory symptoms. So these inflammatory factors lead to stimulation of the nerve endings, and they can cause pain, urgency, frequency, as well as damage to the epithelium. So how to evaluate the case of bladder pain syndrome? First and foremost, history is important, followed by focused physical examination, frequency volume chart, which is very important in every urogynec case. Cystoscopy is must to diagnose as well as to define the type of interstitial cystitis. So history indicating bladder specific like symptoms of pain, pressure, discomfort, which is linked to filling phase of the bladder with lower urinary tract symptoms. Other organ symptoms like endometriosis and bowel symptoms can be present. So there may be dyspareunia and dysmenorrhea as well as symptoms of irritable bowel syndrome. Symptoms of hypertonic pelvic floor like dysfunctional voiding, which is well explained by Dr. Aparna and Dr. Monica. There can be hesitancy, interrupted flow, weak stream, straining, incomplete emptying, and there can also be obstructed defecation due to hypertonic pelvic floor like incomplete stool evacuation, aching pain in the anal canal, dyspareunia, low backache, tailbone pain, hip pain, and groin pain. Women are mostly psychosocially abnormal. There can be depression, anxiety, emotional distress, and various degrees of resultant disability, cognitive, behavioral, and sexual consequences. There can also be signs of inflammation like allergic symptoms, symptoms specific to autoimmune conditions like Sjogren's syndrome, scleroderma, and sometimes there can be centralized pain, chronic fatigue syndrome, where there is pain beyond the pelvis involving multiple body or regions. History can be of recurrent urinary tract infection, or there can be some dietary changes like increased consumption of cold drinks, tea, coffee, chocolates, drugs, or there can be geographical translocation. Sometimes there are associated diseases like fibromyalgia, migraine, mental stress, which can also lead to bladder pain syndrome. And we have to look for past history also, that she has gone on a pelvic surgery, any history of urinary stone disease, history of PID, history of pelvic irradiation, or any history of neurological diseases. So just overactive bladder has been well explained by Dr. Meera. So there are some symptoms which are found in both conditions like urgency, frequency, nocturia. But in overactive bladder, there is urge incontinence, while in bladder pain syndrome, there is bladder pain. In 14% cases, both of these coexist. In overactive bladder, women pass urine to prevent incontinence, while in bladder pain syndrome, women pass urine to get relief of the pain. So these are two common conditions which can exist in about 14% cases. So after history, we have to go for the examination. General examination should be carried out gait of the patient, mental status, and somatic signs of anxiety should be looked into, followed by abdominal examination where scars of previous surgery, any abdominal mass like palpable bladder, tenderness in the abdomen, especially in the suprapubic area. Pelvic examination should be carried out, both speculum as well as distal examination. Trigger points, toll of the pelvic floor muscles, and myofascial bands must be looked into, followed by neurological examination because many women of bladder pain syndrome are neurologically unstable. Investigations are not many, but urinalysis, culture, and cytology, especially culture for tuberculosis, if sterile pyuria is found. Sonography of the kidney, ureter, and bladder is done to see the post-mortem received urine. And where there is suspicion of interstitial cystitis, cystoscopy must be done by expert urologists like Dr. Meera, Dr. Amita, Dr. J.B. Sharma sir, under anesthesia because it's very painful procedure. So this cystoscopy should be done to see which type of this interstitial cystitis is, Hanners or non-Hanners, and if there is ulcer, biopsy should be done to rule out malignancy. And except there is no definitive test for interstitial cystitis. Gives criteria for diagnosis. Mandatory things are history examination, bladder diary, urine analysis, ultrasonography, cystoscopy with without biopsy, symptom scores, and quality of life scores. Recommended in selected cases like culture, cytology, pain mapping using a pain body chart, and urodynamic study is optional, is not required in cases of interstitial cystitis. So cystoscopy is a must, which can diagnose where there is thinning of the protective bladder lining and pinpoint bleeding, which are in the form of glomerations of the bladder wall, or Hanners ulcer, where there is ulcerative lesion, a large mucosal lesion in the bladder wall. This waterfall hemorrhage is found in cases of Hanners interstitial cystitis, where the scar ruptures with increasing bladder distension, producing a characteristic waterfall type of bleeding, and bladder capacity reduced due to the increased fibrosis under anesthesia. In non-Haller region, there may be normal bladder mucosa at initial cystoscopy. Glomerations after low pressure hydrodistension is considered to be a positive diagnostic sign, although they can be observed even without bladder pain syndrome. More than 10 glomerations per coordinate in 3 out of 4 is supposed to be diagnosis of bladder pain syndrome. This European study Society for the Study of the Interstitial Cystitis have included cystoscopy and biopsy, and they have diagnosed like normal XA, while 3C is severe, that is Hanners lesion. So they have included biopsy as well as cystoscopy to hydrodistension. So management requires multimodal therapy like physician, dietitian, physiotherapist, pain specialist, psychologist. Our goal should be to relieve pain and to prevent anxiety. So depending upon the type of the injury, like there is urothelial insult, and so there is lower urinary tract dysfunctional epithelium. So in this case, we can give pentosan sulfate sodium to repair epithelial dysfunction, while when there is activation of C fibers release of substance P due to leakage of potassium into the interstitium, we can give tricyclic therapy to modulate neural activity. And when there is mast cell activation, histamine release, we can give antihistaminic therapy to stabilize mast cells. So if these things are not given and treatment is not started, there will be more injury, more urothelial insult, and more destruction of the urothelial mucosa. EU guidelines, American Urological Association have made certain guidelines. First line treatment, general relaxation, stress management, bladder training or pelvic floor relaxation in cases of hypertonic pelvic floor. Patient education is must. Self-care, behavioral modification, and avoid force like caffeine, chocolate, citrus fruit. Second line treatment includes appropriate medical treatment, oral drugs like amitriptyline, cimetidine, hydroxygen, pentosan polysulfate, phenazopyridine, methenamine, and intravesical like dimethyl sulfoxide, heparin, lidocaine. Third line treatment includes cystoscopy under anesthesia with hydrodistension, laser coagulation, transurethral radiotherapy treatment, diathermy of the Hanners lesion, and fourth line treatment includes intradetrusal botulinum toxin A injection, neuromodulation. Fifth line treatment is cyclosporin A, diversion with or without cystectomy, pain management, and substitution cystoplasty. Oral medication, these drugs like nortriptyline, doxycycline, imipramine improve pain by inhibiting reuptake of serotonin and norepinephrine. Antihistaminic, both H1 and H2 receptor antagonists like hydroxygen, 25 to 75 milligram a day, is very effective in mast cell dysfunction, and it can help in the woman's symptoms, to improve the symptoms. Non-steroidal anti-inflammatory drugs Pentosan polysulfate is a very good drug. It is a glycosaminoglycan, heparin analog. It decreases epithelial permeability barrier. Dose is 300 milligram per day, but it requires long duration of therapy, like 3 months to 6 months. And most important side effect or most complicated thing is retinal maculopathy. So we have to check the retina when this drug is being given. Gabapentin can be given, which improves neuropathic pain. Dose is 100 to 400 milligram per day, and sometimes steroid may be required. Cyclosporin is calcineurin inhibitor. It's more effective than sun pentosan sulfate, and is more effective in Herner's lesion interstitial cystitis. Side effects are renal toxicity, hypertension, alopecia. This sertolizumab pegol is a new molecule being tried for the treatment of interstitial cystitis. It's a novel anti-tumor necrosis factor alpha and used in autoimmune diseases. Subcutaneous injection is 400 milligram. So second line therapy is oral amitriptyline pentosan polysulfate or oral pentosan polysulfate with heparin. Intravesical agents can be given like lidocaine, bicarbonate, pentosan sulfate, intravesical hyaluronic acid, DMSO, tacrolimus, or anesthetic cocktail. This, in case of type C, this transurethral roller electrode is given to cauterize the ulcer base and the margin of the surrounding mucosa. And this fourth line treatment includes hydrodestension with submucosal Botox injection, and it is given in the trigon area because this area is rich with nerve endings. So if given in this area, it will help and it will prevent the pain. Sacral pudendal neuromodulation, though not very effective in cases of bladder pain syndrome, but can be tried. Interstream is also a type of sacral neuromodulator. Fifth line treatment is different types of surgery. Urinary diversion without cystectomy not recommended. Supratrigonal cystectomy, bladder augmentation, especially in 50% cases where there is trigonal disease. Subtrigonal cystectomy, the orthotopic neobladder, it needs ureteral replantation, that is favored. Cystectomy, thallial conduit formation is also favored, or patch and clamp cystoplasty. So to summarize, patients suspected having interstitial cystitis, urine routine, macroscopy, culture, ultrasonography with cystoscopy and anesthesia. If it is non-renal lesion, therapeutic is for short duration and oral therapy mostly given. If improvement, then follow-up. If no improvement, then intravesical therapy, again improvement, then follow-up. If no improvement and severe symptoms, then surgery. And in Herner's lesion, biopsy, fulguration, resection, laser, transannular should be tried. And along with oral therapy, if there is no improvement, then again intravesical therapy. And if with this no improvement, then weight, Botox, cyclosporin A, interstitial. So this is the summary of the treatment. So outcome, interstitial cystitis is a chronic condition with a variable course. It is characterized with periods of exacerbations, remissions. It is estimated that about 10% of interstitial cystitis patients fail to have acceptable symptom management with conservative methods. This disease can have a significant negative impact on the quality of the life. Take-home messages. It should be in mind while managing a patient with pain, urinary urgency, and frequency. Initial patient management must include cystoscopy under general spinal anesthesia to find out and treat Herner's lesion. Treatment should be done in planned manner and justified timeline. Both Herner's and non-Herner's bladder pain syndrome can have severe disease. Even patients with a large capacity bladder benefit from reconstructive surgery. Patients should be offered surgery if they don't improve after adequate treatment. Thank you for your patient hearing.
Thank you, Dr. Kavita. Wonderful. Over to Dr. Sandhu.
Thank you so much, madam.
Wonderful, Dr. Kavita. It was very elaborate presentation. Now we move to next talk. Sandeep, you have...
Madam, yes, madam. That Dr. Amita Jain, madam, wants to speak earlier because she won't be able to join after 7:30.
Dr. Amit Tandon will have to tell us.
Yeah.
Okay. Yeah, Amita is requesting since long.
Okay,
so
sir?
because Amita has to travel, so that's why she requested.
Okay.
No problem. Let Amita have the privilege.
Yeah.
No problem.
Dr. Amit for
Oh.
saving me.
Yeah, Amita. Go ahead.
So he's my
Go
senior
ahead.
and always
Yeah. Yeah, you can take this privilege from me. Okay.
Thank you, Amit sir.
Okay.
So, who is going to introduce? Dr. Sandeep?
Yes, Madam Charmila, madam, is there?
Yes, madam.
To give the
Please
talk
introduce
on
Amita Jain, madam.
To give the talk on new trends of iatrogenic fistula and its minimally invasive management, we have an eminent speaker of Amita Jain. and she's a senior consultant at Gurugram, and he is a general secretary to the South Asia Federation of Urogynaecology. May I request Dr. Amita to give her talk.
Hello, Amita madam. Your talk is ready.
Madam, you're muted. Dr. Amita, you're muted. You have to unmute yourself.
Can you hear me? Can I share?
Yes, yes, yes.
We
can hear you. Yeah. Share your slides.
Be a bit louder, Amita.
I hope you are able to hear me clearly.
Voice is little low. Can you make it little higher?
You just increase the volume, Amita.
I have done that.
Come nearer to the speaker.
Okay. I don't know. There is some problem with net. Can you hear me now?
Yeah.
Yes.
Beautiful. Yes.
So my topic is new trends of iatrogenic fistula and its minimally invasive management. If we talk about new trends, you can see that now we are actually having retrogressive evolution. That means that we are not evolving on the positive side. Still, we are having the increased rate of urogenital fistula, but it is now more and more iatrogenic and resulting from cesarean section. We'll think that it would be hysterectomy, but the problem is that now after the invent of Mirena and many other new medications for menorrhagia and other ailments, the hysterectomies are actually decreasing, but is still fistula, the iatrogic fistula is increasing. And this is a very beautiful study in 2014 where 11 countries data was collected and was analyzed, and you can see that around 9.5% is definitely iatrogenic, and if include the probably and likely causes, it will be around 30-40% of the cases. So it is actually increasing, and that's why the conclusion of that paper was that women with previous cesarean section, because they are at increased risk of iatrogenic injury, the work environment should be adequate, there should be adequate training, and also the iatrogenic fistula should be treated as a distinct category of the genitourinary fistula. This is the data from our neighbor country Pakistan, and you can see this published data also showing that there is constantly increasing in the rate of the iatrogenic fistula, which is orange one, but the decrease in the ischemic fistula, which is usually obstetrical one. So we think that we are not doing difficult obstetric surgery, but because of the higher rate of the cesarean section, you can see in overall all countries are having more and more cesarean section, and that's the reason that in Tanzania it is reported that 85% of the patient developing fistula now deliver in hospital. So it's not the home delivery or difficult obstetrical delivery, and it is usually by cesarean section, which is increasing the rate of vesicocervical or vesicouterine iatrogenic fistula. So what is the threat? Mostly cesarean section is now done by most junior person, and few countries, even I heard about Indian policies as well, that non-medical clinical officers are trained to do cesarean section in remote areas. And also because of the repeat cesarean section, the chances of these complications like placenta previa creta are increasing, and it will make the surgery difficult. Hemorrhages are there, and these will lead to inadvertent injury to the bladder and ureters and fistula formation. Again, other trend is increased performance of the minimally invasive surgery by abdominal route, like laparoscopy or robotic surgeries. And you know that thermal devices are being used in these surgeries, which could also be the reason. The iatrogenic bladder injury, we will think that what could be the common cause? All kind of hysterectomy can do that, but it has been seen that vaginal hysterectomy has a overall lower rate of having ureteric injuries or even the bladder injuries. You know, obviously, what is the reason? We are able to separate out these structures easily via vaginal route. So that's the thing. Otherwise, overall risk is 0.1 to 4%. And you can see that what could be the reason. Either while doing the vaginal curve dissection, you have done unrecognized cystotomy, or there would be a suture through that wall, as you can see in the picture, or it could be a tissue necrosis from cautery. So these kinds of fistula will result after a few weeks sometimes, because of the gradual necrosis and disintegration of the intervening tissue. So these could be the factors. So American College of Obs and Gynae advocates that whenever feasible, the vaginal route is preferred method for hysterectomy, which we are gradually forgetting. Everything is being done abdominally through laparoscope or robot. So that's the eye-opening thing which you should understand, that vaginal hysterectomy has overall lower rate of all complication, length of hospitalization, everything is lower. If it's feasible, do vaginal. Also for the iatrogenic ureteric injury, it is almost 1% of the total genitourinary trauma. 3 out of 4 are iatrogenic, or mostly it is because of the gynecological surgery. Like you can see in this picture, the endometriosis. What happens in endometriosis? The endometrioma can directly involve extrinsically or intrinsically the ureter. It can actually deviate the ureter medially away from the normal position, and also sometimes there would be a lot of intraperitoneal adhesions and ureter visualization would be difficult. So while doing this surgery, you can see that I just looked that yes, there is some fluid is coming in between, and it is the ureter. You can just appreciate. So intra-op recognition is also very important. So it was ureter while doing the surgery. There was a spurt of water which was coming while doing this adhesiolysis. So overall facts and figures suggest that because the urinary tract injuries are prevalent, it is not very less, 0.3 to 1%, though the bladder injuries are 3 times more common, but usually bladder injuries are because of the lysis of the adhesions, but ureteric injuries are usually thermal injuries. And if we are able to recognize it while doing the surgery, it could be the best. But in open surgery, 1/3 of the ureteric injuries are recognized, but not with the laparoscopy or robotic route. So we have to keep a high index of suspicion. And that's why a good training is required. And there should be a willingness of doing cystoscopy after performing any complex surgeries. As you can see in these videos, that how, after doing even the sling surgery, you can see through cystoscopy that how you have injured the bladder. And you can see that if you are not able to recognize, there could be a stone formation, drain is inside the, all these things, injuries, how you will recognize it will via cystoscopy. So that's the reason that University of Michigan advocates that universal cystoscopy should be done even after benign hysterectomy. And because if we will do that, the data suggests that twice as many injuries were detected during surgery after implementation versus 24%. And the prevalence is delayed, and the prevalence of delayed ureteric injury also decreased by 7-fold. So these are the promising data. Again, if we are not able to identify red flag signs in patients of high risk, what could be the high risk patients prior uterine surgery, when the cesarean section, myomectomy, anything, endometriosis, infection, diabetes, atherosclerosis, pelvic inflammatory disease. These 3 causes could be, or 4 causes could be, because of the higher rate of the infection, the tissue quality is not good. Obesity, again, there could be a lot of fat will obscure the vision. The prior radiation therapy, adhesions are there, tissue quality is not good. So you should be able to grade that bladder trauma. That is graded by looking at the proximity of the injury to the vaginal cuff. So you can download this grading, and then you can see how much is the risk. And again, operative approach matters. As you can see, even for the radical hysterectomy for cervical cancer, the risk is on 1 of 8 out of 87. But if it is done for benign cause and vaginal hysterectomy done, the risk is much reduced. This is only 1 of 3861. Now, even for the ureteric injury, what could the risk factors? That if the is not very clear, especially at the time of intraoperative hemorrhage. The bleeding is there and you want to take uterine or any artery, and you're not able to look the structures very nicely. Underlying diseases are there, a lot of adhesions are there, previous pelvic surgery, radiotherapy. These are the high-risk patients. So at least we should be able to identify at the time of surgery, and also the cystoscopy will help. These could be the different mechanisms. So, it could be even the transection ligature or crushing, or even simple angulation. If you're doing a suture very nearby, then probably angulation of the ureter can cause obstruction and would be detrimental for your kidneys. So you can see that you have to be very, very, there should be a low threshold for post-operative imaging if a patient is presenting with fever, abdominal pain, port side pain, leukocytosis, or even sometimes there could be a mass because of the formation of urinoma. So that's why there should be a very safe and equipped working environment. If at all you are working in a remote case and a difficult surgeries are there, it's better to refer the patient. Otherwise, you have to understand that how to adopt to do these kinds of surgery in limited resources. This is a very nice paper which is recently published. Now coming to a case scenario, like suppose this is a kind of patient you are getting a simple case of fistula. So you can see that how the fistula you can clearly see on cystogram and MRI. Now what will you do? Whether you will repair it for the vaginal route or abdominal route. How will you decide? Abdominal route is advocated once the fistula is very large, location is very deep, high in the vagina, radiation, or you are not able to access it through vagina because of the narrow vagina, or there is some requirement of additional procedure like ureteric implantation or small capacity bladder required augmentation, or patient is not able to lie in lithotomy. These are the few indications. Otherwise, I am also a vaginal surgeon. Most of the fistula repair I do vaginally. So what could be the benefit of minimally invasive approach? You all know all these benefits: improve visualization, precise dissection, the dexterity very good, the instruments, especially of the robotic route, are very, very nice. And 78% of the patient can be discharged on the same day when after the these kinds of high-end surgeries. You can see the so small scar marks are there. So this is just a small video where already because of the injury, genitourinary tract injury, there is a formation of urinoma. So I just want to show you this video that it won't be even difficult even to localize that where is the ureter, where is the injury after long term case of injury, especially the ureter. So this was the patient where we were not able to localize the continuity of the ureter. There was some kind of injury to the ureter. So it seems that yes, every tubular structure once we dissect seems to be a kind of ureter, but gradually you will come to know that yes, it was not ureter. There could be lot of adhesions, and you have to dissect deep and deep to finally find out the ureter. So sometimes even the peristaltic movement, which is typical of ureters, is not present because of the injury. So it's very, very important to do a very nice, and you have to be very meticulous in doing the dissection. Now you can see it is the ureter, and you can appreciate. Then you have to dissect it up to that part where the disease part comes. So that's very important. So you have to gradually you have to trace the whole ureter. Very vigilant about not injuring the blood supply of the ureter, because if there could be sometimes necrosis of the ureter later on in the future. So now this ureter will be identified. Now, this is another case where the ureter were good, but there was vesicovaginal fistula, which was very, very near to ureter. So sometimes even in these patients, you have to think of doing ureteric implantation because of the healing. There could be problem at the vesico-ureteric. Just finishing, center positioning flaps could be either omental flap or sigmoid epiploidy, which will be very easier to see that how you can take it once you are using minimally invasive routes. Sometimes even it is not required. And there could be two routes: transvesical approach, where you have to do a big cystostomy, and then you have to see the fistula after opening the bladder. So it's required a long incision, and you have to repair the bladder. So nowadays we are not doing that. Nowadays we are just doing the extra vesical approach, where we are just going through the fistula, directly. So we are just identifying the fistula site, and then we can, minimal incision on the vagina, and we can see the fistula site and we can repair. So there are some few V nodes kind of things are there which are now prevalent. I think in AICOG we are covering these kinds of modalities, single port intracycle approach. You can see that how the fistula repair is done by putting the port inside the bladder, and now this is the fistula site where the repair is done through bladder. So these are the few minimally invasive approach, and I think that to succeed for these kinds of procedures, a training, a good knowledge of technology is required. Thank you so much. If you want any question, you can ask. Thank you so much.
Thank you, Amita. I know you are have to have some other commitment also. So thank you so much for joining. So we are a bit late. Okay. So thank you so much. The topic was very nice, and I think everyone faces such type of complication in their life. So this is good. So yeah. So next speaker is Dr. Amit Tandon. He is robotic surgeon, laparoscopic center, an ex-assistant professor, Department of Obstetrics and Gynae, Agra, Vice President, UP Chapter, IGA, ex-secretary, Agra, and he had a fellowship also in Gynae Oncology from Tata Memorial Hospital. So I invite Dr. Amit Tandon to present his talk. So
thank you, ma'am. Thank you for the opportunity. Thank you, ICOG, for giving me this opportunity. So, can you hear me clearly, madam?
Yes, yes.
Okay. So my topic is on Birch corpus suspension. So, as we all know that Birch corpus suspension is an effective surgical procedure for stress urinary incontinence. It may be performed through an open or a laparoscopic approach. Laparoscopic approach, when compared to the open Birch, laparoscopic Birch corpus suspension has been shown to be equally effective. The minimally invasive approach offers additional benefits such as low perioperative complication rates, a shorter hospital stay, and faster return to daily activity. Since the advent of the mid-urethral sling, which was considered the new gold standard, which offered a minimally invasive approach with a similar long-term efficacy as the laparoscopic Birch, which mid-urethral sling overtook the Birch. Nonetheless, the role of Birch today is in recurrent incontinence and as a primary treatment when done along with hysterectomy, maybe laparoscopic, open, or other. So options for recurrent incontinence are urethral bulking agents, repeat sling, and Birch corpus suspension, which can be done as a primary procedure along with a hysterectomy procedure. So Birch as a primary treatment can be done at a time of concomitant surgery and surgical options that does not involve graft placement. Since the FDA issued warning in 2008 and 2011 regarding the use of vaginal mesh, patients are increasingly more interested in non-graft options for the treatment of prolapse and incontinence. So the objective of this presentation is to illustrate anatomy pertinent for the Birch corpus suspension and to describe technical aspects of this procedure when performed by a minimally invasive approach. So for Birch corpus suspension, we need access to a space called the prevesical space, which is present between the bladder and the pubic symphysis. One has to be careful by approaching this space because there are thin blood vessels present in this space which can cause torrential hemorrhage. So this is what you see is the pectineal ligament. This is the Cooper's ligament. Below this is the obturator canal and the obturator artery, vein, and nerve. And when doing Birch corpus suspension, one has to be careful because from pubic symphysis, this plexus is roughly 6 centimeters and 2 centimeters above from the below the Cooper's ligament. So one has to take care that one doesn't go very lateral while doing this surgery. So now anatomy, which is pertinent to Birch corpus suspension. On one is the pubic symphysis. Here is the pubic tubercle. And 7 is the Cooper's ligament. And 8 is the tendinous arc of the levator ani. And 2 is the periurethral and the perivesical tissue, which is used for Birch-Calpo suspension. So when we do Birch-Calpo suspension, the assistance from below pushes a finger in the and elevates the paravesical and the paraurethral tissue up, and the elevation is up to the level of the tendinous arc of the levator ani. One has to take care that one is not too lateral so that to injure the obturator vessels and the external iliac vein. So roughly we take a distance of 3 to 4 centimeters from the pubic symphysis for taking the stitches. The assistance with the help of the finger is elevating it, and we take a longitudinal stitches roughly 1 to 1.5 centimeter apart. So now we are presenting a case of Birch-Calpo suspension. First, the assistants fill the bladder with help of 300 ml saline. And here and we give an incision roughly 2 centimeter above the highest dome of the bladder. And once we dissect the peritoneum, we extend the peritoneal incision laterally. And this is a complete peritoneal surgery. So one has to take an oath literally that they will not dissect anything else except the peritoneum. Once you dissect the peritoneum and you carry on the incision laterally from the median umbilical ligament to the medial umbilical ligaments on both the sides, just medial to the inferior epigastric vessels. Once you have sufficiently dissected the bladder from the anterior abdominal wall, then you can empty the bladder so that because of the weight of the urine inside, the fluid inside, the bladder itself pushes itself down and helps in dissecting the space of Regius, which is between the pubic symphysis and the bladder. So here you can see the space is being dissected. And once we have dissected the space sufficiently, we empty the bladder and we go into the cotton candy tissue space, and gradually we extend our incision laterally, and we can see the Cooper's ligament, which is a white shining ligament on either side. And in the median, there are ligaments which are supporting the urethra. We may not cut them, and we have to dissect laterally until we reach the pubic arch of the levator ani on both the sides. Here you can see that the dissection is being carried on the left side, and the bladder is being separated from the pubic, the Cooper's ligament on both the sides, and the cotton candy tissue space is being dissected. Once we are into the lateral paravesical space, the fat which is lying over the lateral vaginal wall is being dissected medially so that to expose the paraurethral space. Then roughly 2 centimeters 2 centimeters from laterally, and we know that the urethra is 4 centimeters. So mid-urethral region, a stitch is taken from the paravesical tissue up to the Cooper's ligament. And normally the suture which we use is Ethibond suture. Here you can see that the suture is being taken, but the suture is not completely tightened. It is Birch-Calpo suspension. So we have to suspend the vagina from the Cooper's ligament. Here you can see that the Cooper's ligament is being suspended. The lateral vaginal tissue is being suspended along the Cooper's ligament. Once we have taken one stitch, then we take another stitch on the left side, or we can take alternately. So the dissection on the left side, we do suturing from the right side. And from dissection on the right side, we do suturing from the left side. So this is how the intercorporeal suturing is done. Once the suturing is done on one side, the same procedure is repeated on the other side. Here you can see now we are doing dissection on the right side, and we are separating the paravaginal tissue on the right side. So once we have taken similar steps as we've done on the left side, we've suspended the lateral vaginal tissue up to the level of the tendinous arc of the levator ani on the right side. And then we take another suture and suspend the paraurethral tissue again at a similar level. So once we've completed the procedure, we do peritonization and close the peritoneum. So this is another case where we have done Birch-Calper suspension along with a lateral paravaginal repair. So here you can see that we have again dissected the cotton candy tissue on both the sides, and we are carrying on our dissection laterally along after exposing the Cooper's ligament on both the sides. If we have to do a paravaginal repair, it is done primarily before we do the Birch-Calper suspension. The assistants from below push the fingers down and exposes the levator. And here you can see that the Foley's is in the bladder, and one can decide the position to take the birth stitches. So here, but because this patient was having a lateral cystocele also, so paravaginal repair was done initially with the help of ethibond and proline sutures. So the from this dissection is done from pubic symphysis to the ischial spine, and a series of 3 to 4 sutures are taken laterally. So lateral cystocele repair also at times helps in treating some component of the stress incontinence. And then once this procedure is complete, we can go ahead with doing the paravaginal repair, the Birch-Calper suspension. Once we have done this on both sides, with the help of guidance of the Foley's inside the bladder, we can see the mid-urethral region, and we can take sutures in the Cooper's ligament on both the sides, 3 to 4 centimeters from the pubic symphysis. So here you can see that we have taken sutures from one side. So this is the final placement of the suture. This is the urethra, and the distal suture is taken 2 centimeters from the urethra in the mid-urethral region, and the proximal suture is taken at the bladder neck 2 centimeters from the bladder neck. So this is the final picture which you can see post-surgery. So sometimes, the Birch-Calper suspension, sometimes you happen to tighten it too much, or the patient is having some voiding difficulty. In those cases, we need to sometimes cut the birch stitches. So this was one similar case where surgery was done, and after 3 to 4 days of conservative treatment, the patient did not got relieved of the urinary retention. So we had to go ahead and cut open the suture. By that time, there were dense adhesions. So we have to do our dissection gradually so that we could go up to the pubic symphysis, dissect the bladder after filling the bladder, and went ahead with cutting of the sutures. So we cut the distal suture on both the sides. One, the suture got exposed in the Cooper's ligament area. So once we've done the suture, then we again close the bladder peritoneum, and the patient was relieved completely after that. So now objective cure rate of Birch-Calper suspension. There's various authors have done their study, and they found up to 80 to 90% relief. The Jarvis meta-analysis, which was done of 2,300 patients, shows a 84% relief of Birch-Calper suspension. This is a Cochrane database review, which summarized 39 trials of 3,000 women. For first year, there's found a relief of 85 to 90%, and 5 years relief was of 70%. There was no significant difference between open and laparoscopic approach. Complications after Birch-Calper suspension can occur in form of detusor overactivity, 5 to 10% cases, voiding difficulty in 10 to 15% cases, apical and posterior compartment prolapse in 5 to 10 7% cases. So what are the other risks which can occur? Bleeding during the dissection of the space of LCS, particularly at the time of a repeat retropubic procedure, can occur, where hemostasis can be achieved by direct pressure, sutures, or vascular clips. Less severe bleeding usually stops after tying the suspension sutures. Bleeding during the sutures may also be inadvertently placed too medial, penetrating the bladder, thus cystoscopy is warranted. Injury to the obturator or the external iliac vessel may lead to catastrophic hemorrhage. So Birch-Calper suspension, in conclusion, remains an important management option of stress urinary incontinence. It is appropriate for patients who have failed treatment with sling or who decline synthetic mesh placement. It is particularly suitable for when performed at the time of another laparoscopic procedure. So thank you so much.
Thank you so much, Dr. Amit, for your brilliant presentation, and your videos were really very nice. So I think the delegates who have joined must have learned a lot. So how to proceed even open or laparoscopy with laparoscopy, and as well as how to once if this suture is very tight, how we can again go for reopening and how we can lose it. So I think these delegates must have benefited. So thank you so much for the joining and for presenting
Thank
such
you,
a bit.
Dr. Amit Tandon. It was wonderful and crisp presentation. And also you finished in time. That is also
That is very important.
So it was the last presentation and you did very well. Now we
Ma'am,
request
link has been posted in the chat box, ma'am.
Okay, okay. So link has been posted.
right now. Okay, so all the participants kindly go through the questions. We will also see.
Thank you, madam. Thank you, Suman Sinha, madam. Thank you, Sandeep. Thank you,
you, sir.
everyone, for this opportunity. Okay.
Welcome, sir. Welcome.
So link has been posted and there is also QR code. You can just take the QR code, take a picture of it, scan it, and you have the questions. So you'll be given 15 minutes. And Shreya, there is one request from the participants. They want mm, what to tell you. 1 minute before, you just tell that only 1 minute is left.
Okay, ma'am.
So that they will hurry up. Hello.
2 minutes left. There is only 1 minute left. Please submit your test. Twenty seconds left.
So can we have the answers?
Yes, ma'am.
Not visible. Yeah. Yes. Dr. Sandeep, can you see? Dr. Sandeep, you are muted. Please unmute. आप अनम्यूट कीजिए अपने को. कर नहीं पा रहे हैं. Please unmute Dr. Sandeep.
All right. Okay.
Okay.
So there are 20 questions, which are multiple choice questions. The answer to first question is overactive bladder refractory to modifications. Then the answer to second question is botulinum toxin type A. The answer to questions 3 is 3 to 6
Read the
months.
questions. At least read the question. Number 3 is what is the approximate?
What is the approximate duration of effect of intravesical botulinum toxin injection? The answer is 3 to 6 months. Fourth question was what could be the reason for the ureteric injury in endometriosis? The answer is all of the above. D option is the answer. And I'm not able to read it properly because it is blurred.
Yeah.
And then next question was what are the risk factors for future vesicovaginal fistula formation except? The correct answer is low BMI. Sixth question was what are the energy-based devices? Answer is D, all of the above. That is laser, RF and HIFU. Yeah, now it is clearly visible. So the seventh question was what is EBD's mode of action of in SUI management? The answer is collagen neogenesis. Eighth question was the definition of intrinsic sphincter deficiency is. The correct answer is A. Valsalva leak pressure point pressure less than 60 centimeter water and or maximum urethral closure pressure of less than 20 centimeter water. The ninth question was the parameter not noted during cystometrogram is. The answer is pelvic floor relaxation. 10th question was which of the following is not a component of standard urodynamics? The answer is urethral pressure profile. 11th question was bladder pressure during cystometrogram. The correct answer is does not rise with increase in the bladder volume. 12th question was which of the following best defines stress urinary incontinence as per the International Continence Society? The correct answer is involuntary urine loss associated with increased intra-abdominal pressure. The 13th question was which of the following is not an indication for performing urodynamic studies during before SUI surgery? The correct answer is uncomplicated clinically confirmed SUI. 14th question was which of the following materials can be used for autologous pubovaginal sling? The correct answer is rectus fascia. 15th question was during the dissection in the space of radius for birth corpus suspension, injury to corona mortis can occur. Which statement regarding corona mortis is correct? The correct answer is option A. It is an anastomosis between the obturator vessels and the inferior epigastric vessels. Question number 16. In birth corpus suspension, sutures are placed between. The correct answer is A. Pubocervical fascia and Cooper's ligament. 17th question was which of the following is the primary symptom of bladder pain syndrome? The correct answer is suprapubic pain, pressure, or discomfort related to the bladder. 18th question. What is the typical duration of symptoms to diagnose bladder pain syndrome? The correct option is D, 6 months. 19th question was which of the following defines recurrent urinary tract infection in women? The correct option is B, more than 2 urinary tract infections in 6 months or more than 3 UTIs in 1 year. Last question was the most important risk factor for recurrent UTI in postmenopausal women is hypoestrogenism leading to atrophic mucosa. The option B.
Thank
The
you,
questions
Dr.
are over, madam.
Yeah. So thank you, Dr. Sandeep. Can we go for the vote of thanks?
Yes, madam. Yeah. So thank you, Foxy, and the team ICOG for giving me this opportunity to act as a coordinator. I would like to thank Dr. Parag Beniwale, Chair ICOG, Dr. Sheila Mane Madam, the Chair-elect for ICOG, Dr. Sadhna Madam, ICOG, then the convener, Dr. Suman Sinha Madam, for really helping me out to design this. This is one of the first ever experience of conducting such webinar. I learned a lot of things from this, madam. And thanks for you, madam. I would like to thank all the speakers, chairpersons, guests, and participants for sharing the knowledge. I would like to thank the technical partners from the Foxy, Mrs. Nilima and Shreya, for giving their technical support. And they were all ready to solve all our queries as and when required. So thank you, Nilima and Shreya. And at the last, I would like to invite all of you for tomorrow's session on there is a third day session from 4 to 7 p.m. So thank you.
Thank you, Sandeep. Well done. It was your maiden attempt and you did it so well. Thank you so much. Thank you, Vidya Madam, for staying till the last
Thank you, Dr. Suman, Dr. Kavita, and Dr. Sandeep. Today's session was wonderful and nicely conducted, and I was there. It was very nice. Yesterday's was also nice. It was